Good afternoon, sir.
Good afternoon. Am I audible?
Yes, sir. Sir was just waiting for
Yeah, no problem.
Shivaraju, sir, and Mala, madam. So
Okay,
let them join, and afterwards we'll start.
okay. Can I test my PPT 1 minute?
Yeah, please, sir.
You have given me the permission, isn't it?
Yes, sir.
You cannot start screen share while the other participant is sharing. Something is showing now.
Okay. Divya, okay, now, sir, you can.
Okay, let me check. It is showing again, join the meeting. Some confusion there. Let me try. Yeah. Is it visible now?
Yes, sir.
Okay, then I will stop now.
Okay.
Okay.
Okay. Good afternoon, sir. Shivaraju, sir, good afternoon.
Yeah, good afternoon. There is some disconnect. I'm joining again.
Sir, your voice is so low.
Is it? Am I audible?
Yes, sir.
Yeah, I am here. So, you had your lunch, everything?
Yes, sir. Yes, sir.
So, exactly now 2 o'clock, we can start, or you will be? Professor.
Sir, I'm just waiting for the next presenter.
Yeah.
Dheeraj Bhatia, Dr. Dheeraj Bhatia, I think he has not yet joined.
Okay.
Tivishekar sir is already there.
Professor Sekhar is here. What about Professor Mala Kapoor?
She has also not joined.
So, that time slot only they may join then.
Hopefully.
You can send a message.
Yeah, that message already sent. Yeah, I'm just
already sent.
Yeah.
So what I suggest is, because you have there will be chain delays, because this is the first session. What I suggest, you start punctually and let Professor Sekhar present, and by the time others can join. Anyway, Professor Sekhar is the first speaker.
Yes, I think we'll start. I think better we'll start, and in between these people will join.
So that I think, is it all right, Professor Sekhar?
Yeah, fine for me.
Okay, then good afternoon again. So today we have the session. This is the fourth session, and here we have. This is mainly the healthcare policies for the elderly, and these sessions will be chaired by Professor Shivaraju sir, and he's a former professor at the Center for Excellence in CSR at TISS, in an expert in corporate social responsibility, population and development and aging. He has contributed a research on the resettlement, health and development of elderly population in India, and is a key figure in CSR and rehabilitation studies in India. So thank you so much, sir, for agreeing to chair these sessions. Please, sir, please go ahead. Now, session is yours.
Yes, thank you, Professor Dhananjay. And we have the theme of this session is on healthcare policies for the elderly. We have 3 speakers, and first speaker is Professor T.V. Sekhar from IAPS. His introduction, I think everybody knows. Professor Sekhar's contribution in the field of aging. I think he's one of the senior professors in IAPS. Earlier, he was in Isaac, Bangalore, and he is also now coordinating a LASI long-term project. and also has published several, he has created several publications and also regular speaker in various platforms, seminars, conferences. And furthermore, I am very happy to express my association because Professor Sekhar is president of. Why? Is it clear? There's a lot of resound coming. Yeah. So, Professor Sekhar is also president of Indian Association of Social Sciences and Health, the organization in which I was also associated. And I'm very happy that Professor Sekhar is going to present on the topic health of elderly in India, emerging challenges. I think Professor Mala Kapoor also joined. She will be the second speaker, I think, after Sekhar's presentation. Professor Sekhar, I think 20 minutes is okay? Your silent mode you have kept.
Yeah, it's fine
Yes.
for me. Yeah.
Please, I request Professor Sekhar to start his presentation.
Okay. Am I audible?
Yes.
And the PowerPoint is visible?
Yes, absolutely.
Okay. So thank you, Professor Shivaraju, for a very generous introduction. And I am happy to present in this panel on healthcare for the elderly. I think this is one issue where a lot of research and attention is required now, considering the expanding population of India's older adults. As all of you know that by 2050, India will have approximately around 320 million elderly, and taking care of their health insurance, caregiving, long-term care, all that going to be a big challenge for the country, for the households, for the individuals and the families. And so keeping that in mind, I'm just going to raise some of the emerging challenges in the health sector for elderly and what can be done to improve the situation. Okay, as you see, there is a greater burden of illness among the elderly compared to other younger age groups that also require greater healthcare needs and healthcare attention. And there is a rapid increase in the chronic diseases like hypertension, diabetes, heart problems, dementia among the elderly. And all of you know the prevalence of non-communicable disease is increasing all over the world. And India is also no exception to that. And we need to have a good idea about the prevalence of these diseases to have appropriate policies and healthcare programs to prevent and control of these NCDs. But in our country, particularly in Indian context, though there are large number of aging studies done by various organizations at various points of time, the health-related data was really missing, and a nationally representative survey to provide the health status of India's elderly was very much required. Keeping that in mind, and under the initiative of India's Ministry of Health and Family Welfare, Government of India, we launched a major initiative called the Longitudinal Aging Study in India, LASI, and this is a survey which covers both social, economic, health, including the mental health dimensions of India's rapidly growing elderly population. For those who are not familiar with the LASI study, let me take 1 minute to tell you what is about. LASI provides national level estimates. It also provides state level estimates for all the states and union territories of India. In addition, We also have the estimates for 4 metropolitan cities of Mumbai, Delhi, Chennai, and Kolkata. LASI sample includes those aged 45 and above from the selected households. So in the wave 1 of the LASI survey, this is a longitudinal survey. We are going to follow this panel for next 25 years. In the wave 1 survey, when we carried out in 2017 and 18, we covered 73,396 individuals across the country. Out of that, roughly around 32,000 of them are elderly persons, and around 7,000 of them are 75 plus elderly. And so the second wave of LASI, we are going to initiate shortly now. We are almost ready for launching the survey, where we will be going back to the 73,000 individuals we interviewed in the wave 1 and collecting the information about their social, economic, and health conditions and changes over the last few years. Unlike many other health surveys, one great advantage of LASI is that LASI have a wide range of direct health examinations and biomarkers. We are testing the respondents for their blood pressure, pulse rate, lung function test using a spirometry, vision test. We also have a set of anthropometric measurements like height, weight, waist, and hip circumferences. And more importantly, LASI survey also collect blood samples through the dried blood spots, as you can see here in the screen, and testing for anemia among the elderly, the hemoglobin, the diabetes levels, and all other things. And we also have a performance-based markers like grip strength, timed walk, and balance test. So it is not only the self-reported health condition of elderly in India, but also actually measured health conditions of elderly in our country is given by LASI. As you can see, the self-reported prevalence of cardiovascular disease among elderly in India is around 35%. This includes hypertension, heart disease, and stroke. And among the elderly, the hypertension is the major issue. Around 32% of the elderly 60 plus population are suffering with hypertension, and diabetes is also a major concern, around 14% among elderly. This is actually the self-reported by the respondent. But when we took the actual measurement, actual testing on this, the prevalence is much more than that. I will come to that little later. So as you can see, the age-associated rise in the prevalence of chronic health conditions is steady and consistent, and it is more visible for the cardiovascular and lung diseases. As the age advances, the prevalence increases considerably among the population, particularly the elderly population. So the cardiovascular disease, what we call here, is a combination of hypertension, heart disease, and stroke. Those who are suffering from any one of these, all 2 or 3. So overall, the self-reported prevalence of diagnosed cardiovascular disease is around 35% for the elderly in India, and it is increasing with the age as expected. It is higher among elderly women compared to elderly men. So there is a gender divide here. And 50% of elderly residing in urban areas were diagnosed with any one of the cardiovascular diseases. And when we talk about the self-reported prevalence of hypertension and measured hypertension, there is a big difference. The self-reported hypertension was 32%, but when we tested using the Omron BP monitor when doing the field work, it was around 36%, a 4% difference. This mostly among the poor elderly, mostly from the rural areas. So the self-reported hypertension and measured hypertension is considerably different, particularly in the rural areas and the poorest segments of the elderly population. And when we come to the body mass, the hypertension, we also did some more analysis on this. We found that 42% of them are reported self-reported hypertension they are adequately treated for hypertension. Hypertension is under control. But what is more important is nearly a third of elderly are undertreated for hypertension, and more importantly, 1 in 10, around 10% of elderly remain untreated for hypertension. They are aware about hypertension, but they are not taking any medication or treatment. And the untreated hypertension is almost 2 times higher in rural areas compared to the urban areas. The health situation, health conditions of elderly living in the rural area is going to be a major challenge we are going to face. This is about the multi-morbid conditions. Elderly with no morbidity, it is showing something around 40%, but those who are having single morbidity is something like around 32% chronic conditions, and all those who are multi-morbid conditions around 24%. So it is not only they are suffering from one chronic disease, sometimes 2 or 3 chronic diseases, which needs a lot of medical care, attention, treatment, hospitalization, and other things. And another dimension which has received very little attention when we talk about nutrition and anemia, we always talk about the young population, women, children. But for the first time, Lassie gives us some idea about the situation among the elderly. 27% of the elderly are underweight, and nearly 22%, a fifth of the elderly are overweight or obese. So we have two problems, dual burden of undernutrition as well as overnutrition. Many are suffering with the underweight, and good number of them, nearly 1/5 of the elderly, also have the problem of overweight and obese. And considering the lifestyles and other things, this prevalence level is going to increase considerably in the coming years. The mental health is another issue which has received very little attention in Indian context, and particularly among the elderly. Not many studies looking into the men. Using an internationally recognized measurement scale, we found that around 8% of Indian elderly are suffering from major depression, around 8%, based on the CIDF-SF scale. And you can see there is a considerable difference between the men and women and rural and urban areas. It is more among the women, more in the rural areas, but the overall prevalence is around 8% depression among the elderly. That is another segment which needs a lot of attention in the coming years. So by 2050, even if you go by the 8% depression among elderly, it will be around, by 2050, it will be around 26 million elderly. And another study associated with the Lassie DAD study, it's another study called the Diagnostic Assessment of Dementia. They found the prevalence of dementia is around 7.4% among elderly in India. That means currently around 8 million Indian elderly have dementia now. That is a scenario now. It may be a little alarming, but the number is going to increase next 2 to 3 decades. So we need to be prepared to take on these health challenges. And we also did some analysis based on those who are able to manage their own activities of daily living, like taking care of their, they are able to do their own work, like changing the dress or taking a meal, using the toilet or getting up from the bed. And those who need the assistance or those who have limitations, that number is going to increase considerably in the next 2 to 3 decades. And those who are suffering from disability and impairment, that number is also going to increase considerably in the next 2 to 3 decades. And if you do further, those elderly need a helper or assistant to carry out the basic routine activities like ADL. Their number is from 61 million to around 139, 140 million. Actually, it is from 34 million to around 80 million by 2050. And those who need assistive devices like spectacles, supportive devices, wheelchairs, hearing aids, many other things, that number is also going to increase considerably from 61 million to around 140 million by 2050. So there are many things to be done, and a lot of support and assistance will be required to support them. But we also found that only 18% at the time of the survey, when we did in 2018, only 18% of or approximately 1 out of 5 elderly are covered by any form of health insurance. That is a little big concern. But of course, in the recent years, with the Ayushman Bharat and many other schemes, things have improved considerably. So the healthcare expenditure of chronic illness among elderly in India is a significant concern and contributing to the financial burden of older adults. And most of the health cost is coming from out-of-pocket expenditure. And most of these are chronic diseases which needs long-term treatment and more expenditure. So diabetes, hypertension, dementia, depression, and other chronic diseases may increase the catastrophic health expenditure. There are many studies in India which show that the catastrophic health expenditure pushed many families into the poverty trap because the main income earner is seriously affected by serious illness. The family suffered considerably and they are not able to manage it. So the out-of-pocket expenditures and low coverage of health insurance schemes place a very heavy financial burden on elderly and their families. So what are the implications? I have given you the data of the health conditions, health status of elderly. What are its implications in the coming years? You know that population aging is inevitable. It is going to happen. The number is going to increase much rapidly. But how far we are prepared to deal with the expanding and evolving healthcare needs of our older adults? That is a big question. The governments have the major responsibility of providing the economic security, social well-being, geriatric healthcare services. You will see more and more geriatric wards in our hospitals in the future years and long-term care. And as we have seen, there is a significant prevalence of undiagnosed and underdiagnosed diseases, more of hypertension, diabetes, and vision impairment. That is going to be a big issue. And so the economic vulnerability of older population, considering that we need to design the health programs, long-term care, and other old age programs. And there are some sections among the elderly more vulnerable, particularly neglected geriatric population, particularly among the elderly widows, may need more attention. Government of India's Health Ministry have a program called the National Program for Healthcare of Elderly, which has many programs implemented. There are regional geriatric centers, some geriatric hospitals. Now government also have a health and wellness centers recently renamed as Ayushman Arogya Mandir, where the elderly can take some help and healthcare. And most importantly, last week, Government of India came out with a major announcement. That is, all elderly, 70 plus elderly, are going to be covered under the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana health insurance cover. This is a major step by Government of India, which will benefit nearly 6 crore senior citizens of our country once it is implemented. All the 70 plus elderly coming under the Ayushman Bharat health insurance program. So we need a lot of policies and programs which also need significant resources, coordination, and commitment across sectors and stakeholders. Because the government health sector alone cannot do this. There is a lot of involvement of private health sector, voluntary health sector in this. And if you are able to invest these resources properly at this right time, we are sure this is an investment for a future, more a healthier population, more an happier population, and a socially secure older population in our country. And of course, we know that life expectancy is increasing considerably. The current generation will live more years than the previous generation, and the life expectancy is showing all that direction. So the extended years of life of our elderly can be healthier and happier. And if you are not able to take care of their health conditions now, the extended years can be of years of suffering with the chronic diseases, disabilities, and impairments. So there are a lot of challenges for the health sector, particularly to take care of the elderly in the coming years. I will stop here. I think we will have some time for discussion later. Thank you very much.
Thank you, Professor Sekar, for your excellent presentation on health of elderly in India based on the data that is from LASI Wave 1. I think you have very much in a user-friendly way the major findings, and you have crunched that data and presented very comprehensively, at the same time very focused way, starting from self-reported and also touching upon the information that comes out from biomarkers, which is first time such a large-scale survey has covered, starting from blood pressure or anthropometric measurements. So many important wealth of data that has come out, including the underweight, overweight, mental health issues. So they are all, very rich information, which is also very alarming, especially when we are seeing the data that more female elderly are going to suffer, furthermore rural. So some of these challenges which is going to come while addressing the issues for healthcare of the elderly, I think you are right, very aptly presented the data plus your implications that you have highlighted and provided are very important for program point of view, for policy point of view, what lessons which we have to draw and programs that we have to implement. I think I'm sure there will be several other clarifications that our participants may require. We will take it up after 3 presentations. Thank you, Professor Sekar. Now I request, as per the order, Professor Dhananjay. Now Dr. Dheeraj is ready, or Professor Mala
No,
Kapoor
sir,
will
he
present?
will not be able to attend because he's
Okay.
in
Yes.
hospital. So
Okay.
Mala
Then,
Kapoor will be there. I
we'll
think we
go
have
for
only
it.
2 presentations this sessions. Then
Okay.
after we'll have the discussions.
Okay, very good. Okay. Then let me introduce Professor Mala Kapoor Shankardas. So she is, I think, one of the highly committed gerontologists, sociologists, and very much in both the research side and also in the practice side, addressing the various issues in policy making, and also, regularly organizing and also publications. I think Professor Mala Kapoor, more than, I think, 15 publicated volumes, Springer and other international publications. And she was very regular in international fora for addressing issues. I think we are very fortunate to have her presentation here. And Professor Mala Kapoor is going to talk on sustainable aging perspectives, combating ageism, abuse, and empowering strategies. She is also General Secretary, if I am correct, for the International Forum on Elder Abuse. And over the period, we are seeing regularly how the awareness on elder abuse, thanks to her efforts, and also with her creating a lot of platforms for highlighting this ageism and elder abuse, she has brought in. I think Professor Mala Kapoor, now you can make your presentation. Thank you.
Thank you very much. Hear me?
Yes, we are. Yeah.
Yeah. So thank you very much, Professor Shivaraju. Greetings to all. At the outset, I want to state that I'm happy to be part of this virtual conference for various reasons, but primarily that the theme is very close to my heart as it relates to years of my work as an academic person, researcher, consultant, author, and activist. Secondly, I always enjoy being with friends, thus glad to have Professor Shivaraju chairing this session and Professor T.V. Shaker as a co-panelist. Both I've known for long, and many a times we have worked closely on multiple issues. I thank Dr. Dhananjay, now a close associate, as we have worked together in few of my projects, for inviting me to be part of this important meeting, as well as connecting me with many stalwarts and few budding, very promising experts with whom it is always a pleasure to interact. I sincerely hope my talk today appeals to all those listening and something fruitful emerges out of it. Let me move ahead with the topic of my address, Sustainable Aging Perspectives, which I got involved from late 1990s onwards, when, as a UN consultant to review their MDGs, I critiqued in a couple of writings the limited focus on aging issues, which had started to gain importance due to changing demographics. UN member countries soon realized the need to go beyond MDGs, and thus it was superseded by the Sustainable Development Goals, which was to ensure healthy lives and promote well-being for all at all ages. The emphasis on sustainability and leaving no one behind was crucial in all the 17 goals of the SDGs, which gained importance from 2015 onwards. Again, as a UN consultant, I had a chance to contribute towards critically reviewing SDGs in terms of how inclusive they are for older adults and how much do these contribute in improving quality of life of older people. And while many help in increasing life expectancy of populations, but do they lead to making living longer, living better? A question that started dominating a lot of my thinking. Prime for me is the thought, can we have sustainable aging, and what does it involve? As I see it, sustainable aging is about creating environments and policies that support healthy, active, and fulfilling lives for older adults. It is pertinent that focus be on some key aspects. Keeping limitations of time in view, I briefly state 5 elements. I begin with talking about healthy aging as the first element. And I would like to say that for populations, it is pivotal to have opportunities that promotes their physical and mental health through preventive care, regular exercise, and mental stimulation. We do have the UN Decade of Healthy Aging now, which is from 2021 to 2030. And incidentally, both the development goals and this are trying to end their focus, or rather work by 2030, hoping that the countries will be able to sustain themselves by then. So focusing on improving the lives of older people, their families and communities, the UN Decade of Healthy Aging is making good progress. Significantly, it brings attention to intersectionality between older persons, families, and communities, which is necessary. This refers to direct action, partnering with others, and participating in collaborations that work for strengthening healthy aging initiatives. To foster this, in my opinion, It is essential to improve the lives of older people, their families, and communities, for which our societies need fundamental shifts on how we think about age and aging. How do we tackle prevailing ageism across countries, as that is the root cause, in my opinion, for contributing towards increasing elder abuse, neglect, exploitation, and marginalization of older persons. Reports from many parts of the world are indicating elder abuse as a growing menace, and various surveys conducted at different levels point towards this emerging as an important concern that requires strong action to combat it. In India, too, where much is talked about strong family ties, tradition of respecting and valuing older people, research is showing at both micro and macro level as the huge problem that elder abuse is creating in our society and impacting the quality of life of increasing number of older adults. This is my specific field of specialization, as Professor Raju also pointed out. And I can go on and on talking about the need to stop elder abuse and how to go about it with developing empowering strategies, research tools to recognize and document its various dimensions, build management processes at the family, community level, and above all, strengthen voices of older persons to battle against this violation of their rights. I feel government has done a good thing by coming out with a significant legislation, the Maintenance and Welfare of Parents and Senior Citizens Act of 2007, which is at present being amended and waiting for approval by the Cabinet, though has been applied in many states of India. It is similar to many such legislative measures adopted in different countries across the different regions, including in the Asian context, where filial piety has strong hold on society, yet is often broken down because of many changing socioeconomic processes set in by changing family structures, migration and urbanization patterns, technological developments, and if I may say, due to cultural values moving more towards individualism for whatever reason it might be. Drastic steps are required to bring attitudinal change, mindset, and above all, crucially, the environment in which we all exist. Speaking of this from a more sociological perspective, which is my specific domain, I bring your attention to the second element of the key aspects I referred to earlier. The second important aspect which can promote the first necessary element is to build age-friendly environments. What I mean by this is that there is an urgent need to develop communities that are accessible and inclusive, allowing older adults to live independently and participate fully in society. This is absolutely the need of the hour for aging countries. The consequence of elder abuse is that there is a strong violation of the rights of older persons. Their dependent status is a burden. Their participation in family decision making is resented. Their needs are under-recognized, just to name a few dimensions, given the paucity of time. Overcoming these must involve initiatives towards safe housing with adequate space for older persons, be it older men or older women. They must have accessible transportation facilities, and all stakeholders need to work towards strengthening community support that helps in removing vulnerabilities of older persons and enhances their quality of life. As WHO recommends, its member countries and many nations are developing their policies towards this end. It is absolutely essential to have age-friendly environments, since these are definitely better places in which older persons have facilities to grow, live, work, get involved with recreational activities, and consequently age in reduced abusive surroundings. An important question arises: how do we plan this, go about it, that older people, through these measures, can live a life of dignity and respect that contributes towards their well-being? We can create such enabling environments, and this is also a direction given by MIPA, that is the Madrid International Plan of Action on Aging, which is now under review in terms of its implementation. And I'm involved with this process too. So the recommendation is to address the social determinants of healthy aging that can enable all people, irrespective of their level of physical or mental capacity, to continue to do the things they value and live dignified lives. Here, the role of assistive technology is also gaining importance, and simple techniques, products, facilities that can enhance older people to live and feel better as they move on with the years. These are also, in my opinion, necessary tools to reduce the burden of care by family and community, which can facilitate breaking abusive circumstances. Thus, it takes me to move ahead with talking about the most crucial element, and as also stated in the title of my topic for address, that is sustainable aging perspectives for combating ageism, abuse, and empowering strategies. Yes, I'm now going to focus on the third aspect of sustainable aging, which is of combating ageism. Till we don't address stereotypes and discrimination based on age, we cannot ensure that older adults are respected and valued. Our societies are full of ageist views. It is constantly seen in how we think of age. Just look around you and you will see people, especially after a certain age, hesitant to say how old they are. Why? Because it is due to stereotyping age with old age symptoms of frailty, forgetting the fact that today we see 70 years old and 80 years old, even some 90-year-old, active with good cognitive abilities, capable of enjoying good life, provided families and communities let them do so. We need to stop how we think of age negatively, as much as we need to stop our prejudices on age, how we feel about age. Our negative thoughts lead us to our behavior that promotes discrimination against age. We act more often than seldom towards people on the basis of their age. It does affect people of all ages, but has particularly negative effects on the health and well-being of older people. I had the fortune of meeting Robert Butler, the gerontologist, who coined the word ageism many years back at a professional meeting in Netherlands. And since then, we were good friends till his death, when I was asked by his family to write a tribute for him in India, which I could do and get it published in the Hindu, a national newspaper, popular at that time, although now it is under certain controversies. So we many a times talked about ageism and elder abuse, and how different forms of abuse get determined with ageist attitudes, which needs to change as the core strategy to stop elder abuse is to take our thoughts to positive steps about how we think, feel, and act towards age and aging by generating evidence on ageism, building a global coalition to combat ageism, and developing tools and resources that can be used by others to take action. I'm glad to note that in the last couple of years, WHO has taken concrete steps to break barriers in combating ageism. And many countries, including India, are moving in the right direction by adopting a human rights perspective on stopping elder abuse, which in turn leads to sustainable aging. Another pertinent component of my talk is to discuss the fourth element of sustainable aging, which has many consequences on combating ageism and elder abuse, as well as creates empowering strategies. And this is focusing on the lifeline of older persons and contributing towards well-being of aging populations to live longer and live better. Clearly, these are aspects of integrated care, a requirement across generations, as it strongly emphasizes on a life course approach, which a lot of my work promotes, and I cannot miss not mentioning it. And I'm glad that Dr. Satya Narayan in the yesterday's session also emphasized how the life course approach is important in our perspectives on aging. So talking about integrated care, it is for providing coordinated health and social care services that meet the needs of older adults, ensuring they receive the right care at the right time without financial hardship. Now, a common form of elder abuse is related to neglect of health issues, including components of physical and mental aspects. So older people require a comprehensive set of services to prevent, slow, or reverse declines in their physical and mental capacities. These services need to be delivered to meet the person's needs, that is, make them more person-centered. They need to be coordinated between different health and social care providers. And we need to avoid causing the user financial hardship. Lessening the burden of care adds to measures for reducing elder abuse. Ample amount of research indicates that many older people at a certain age experience declines in their physical and mental capacity, which means that they can no longer care for themselves without support and assistance. Access to good quality long-term care is essential for these people to maintain their functional ability, enjoy basic human rights, and live with dignity, as it reduces the care burden increasingly being felt by families and communities, leading to many abusive circumstances and situations. It is a welcome development that countries, including India, are focusing on developing long-term care facilities and programs as part of universal health coverage. I mean, we are bringing emphasis on palliative care, we are bringing emphasis on respite care, and we are bringing emphasis on many other components which can facilitate a better health for older persons. But I won't hesitate to say that that we need to work on this rapidly and holistically from a life cycle approach by understanding what needs to be implemented as a package for long-term care. We need to put in more energy and thinking in understanding, designing, and implementing a person-centered, integrated model of care for people that works as they age. More research is needed to produce evidence that can guide in developing health and social care packages to improve quality of life of older persons, as well as keep in mind the health needs of caregivers from the family and the community. Thus, it is important that we don't lose track of the fifth key element, which I referred to earlier, and it provides groundwork for all our strategies related to empowerment, combating ageism, and elder abuse, significantly leading to sustainable aging. Till we don't have adequate and appropriate policies that take care of needs of population of all ages, we cannot sustain quality of life, leaving no one behind. Therefore, as I come towards the end of my talk, I want to stress on the essentiality of having economic and social policies that cut across age, gender, and socioeconomic groups. Implementing policies that support financial security, employment opportunities, and social inclusion for citizens of a country is pivotal for them to live a dignified life as older adults. This will also help us in fulfilling the 2030 Agenda for Sustainable Development that sets out a universal plan of action to achieve sustainable development in a balanced manner and seeks to realize the human rights of all people. Till attempts are not made to reduce inequalities of all types and promote a dignified life for all, we cannot create a society where aging is seen as a positive and empowering experience. So sustainable aging has to be our goal, and we need to link various economic and social policies towards that. I will end now. Thank you for your patient hearing and hope to be part of discussion in the next course of few minutes. Thank you so much.
Thank you, Professor Mala Kapoor, for your excellent presentation on sustainable aging, highlighting various perspectives that comes out around that, and with a special focus on combating ageism, abuse, and empowering strategies. And you have started with your own association way back from 1990s. I still remember when UNFPA invited both of us. You are focused on qualitative aspects. I was highlighting the quantitative aspects of that time scenario of elderly poor in country, and your own expertise that with all these years of your consolidation of the activities, how the sustainable aging is very relevant and how that has to be viewed from attaining SDGs and bringing WHO's special focus on healthy aging. And your own, with your background of, creating such platforms for elder abuse and ageism, you have very much highlighted how best we have to bring an integrated model and even, viewing from a holistic perspective and taking the, family as a core, issue which surrounds this thing. And you have taken at a macro level also, bringing communities and the society at large. And you highlighted how the MIPA and other international efforts that are going on and how these type of efforts with this case study of India, how the government and human rights perspectives are adding to, highlighting those issues, and your optimism that the government and community-based organizations' effort are in right direction, though much more has to be, taken care of in future. But your optimism, we are sure, will bring fruitful solutions that can be a deterrent for ageism in the society, and also how elder abuse can be tackled, because it is in the guise of the hidden one, which is very, very difficult unless we try to address it and combat that issue. This is very important. So I think you touched upon both policy point of view and also the programmatic response point of view. And I'm sure those aspects will be very good for our participants also to take it further when we are talking about. So I will now, I request the participants, in case, I don't know whether Professor Dhananjay, they have already, if they have put in chat box, you can highlight. Otherwise, those who are interested to contribute now or getting clarifications that you need, speakers are here. Professor Sekhar is here, Professor Mala Kapoor. So in these two presentations, are there any suggestions or clarifications or any comments? You can bring it out. Before I think if others are not having that much, I just want to begin with Professor Sekhar. Now with your rich experience of coordinating the entire lossy wave, what are the specific things last 5 years before second wave? What are your personal observation given the lossy wave one has highlighted? Now, before we move on to wave 2, with your own involvement, what are your own observations that are going to happen in the second round, and what are programmatic and policy responses? Is it that wave 2 findings have to come, then only government will act, or is there any lessons immediately we can put forth for the government so that this will become an alarm for the policy makers?
Okay, thank you, Professor Shivaraju, for raising an important concern and also point. Of course, we are about to launch the Wave 2 survey, and once we get that results, then only we will be able to say what are the changes we have really observed from Wave 1 to Wave 2. But in between, a major incident has happened, that is the COVID-19. As all of you know, COVID-19 impacted very adversely, particularly among the elderly population. And I am sure many of some of our earlier respondents are not alive now. And of course, some may be died due to the age-related issues, but there may be also COVID-related deaths. We don't know exactly, but when we go to that same households, we will know exactly what happened to them. That is one. But I find some areas there are good improvements happening. One is a health insurance cover, which we felt in 2018 was only 18%, now may be much higher. And with the new program announced by the government on Ayushman Bharat with the 70 plus elderly, it is going to have a big impact. And many other health programs. But of course, since the number is increasing so drastically, because in 2011 census, we had only 100 million elderly. And by 2050, it is going to be around 320 million elderly. So that kind of an increase, we need to do a lot of preparations. We are communicating our findings. We disseminated all our findings to Health Ministry, Social Justice, Women and Child Development, Finance Ministry, various ministries, because various ministries are involved in providing some support or care for the elderly in a different way. So it is not only one ministry or one department. So these informations were spread. Government is very keen on that. That is why they felt that we should do the Wave 2 survey and see the changes. And so we will be waiting. We are anxiously waiting to see what are the changes happened and to communicate that change to the researchers, policymakers, and the government. Accordingly they can act. So I see some improvements in certain sectors, but unless until we complete a survey and assess it, it is very difficult to see.
Empirical data has to come out.
Yeah, anything to say.
Thank you, Sekhar. Professor Mala Kapoor, I have one, given this symposium on Asia, now you are, spearheading the movement on ageism and elder abuse. So how do you see the programmatic and policy responses for minimizing this abuse and the efforts that have gone in India vis-a-vis other countries in Asia? Can you briefly give your own observations, because you are a front runner for this movement?
Thank you very much, Professor Shivaraju. I see lots of good practices around us, and we can do learning from them. I mean, of course, Japan has few, but Japan model is quite different from the Indian model in many obvious ways. I mean, their life expectancy, their features of the population of older persons is very different. Although, yes, there are things we can learn from them in terms of, what they are doing for people who are in the older age brackets. Is something which is worth learning. But talking more closer home and more from countries which have similar demographic and socioeconomic situation. So, for example, Thailand or Singapore, or even, some programs in Korea, Malaysia, we are finding that they are being able to, Indonesia also for that matter, are able to achieve a certain betterment in quality of life of older persons. One, because their policies are focusing on older people in a more concrete manner. And secondly, they are generating a lot of community support and response in improving lives of older people. So many of these countries have provisions for community programs, for recreational activities of older people, for livelihood opportunities for older people, for midlife, careers for people, skill training. So that is helping in overall improving the quality of life. And what becomes important is, by seeing such kind of initiatives around, older people are encouraged to think more positively about their age and to
Absolutely.
think more positively about their contribution to society. And there is a big kind of sort of, image change in looking at older people more as a resource than as a burden. So, of course, a lot of it is also happening because of migration of children happening, urbanization. Many older people are increasingly, I would say, older people are living on their own. So that is also creating confidence
Positive.
in them to, be able to cope. And these countries are encouraging facilities.
Yeah.
Transport has improved in many of these countries, whereas in India we lack that transport emphasis, which we need to do. So there are many things we need to learn. And if you remember, you were also part of it, when UNFPA did that knowledge building exercise. In fact, I think you were leading it, if I'm not mistaken. We
Along
did
with
various,
James and
we
Professor
did
Monet.
various studies. And I did a paper and presented also on learning initiatives from other Asian countries. And I think it got published by SAGE or Oxford. I'm not very clear now. So we had, and that paper, what we can take of initiatives from other countries. So I've given examples from Thailand. In fact, I mean, these are still a little more in advanced in certain ways, but we can also learn from Sri Lanka and Bangladesh, who have, Bangladesh has started a very nice microcredit facility where older people are being incorporated in a lot of programs. And Sri Lanka has a lot of nice initiatives on wellness care. So there is a lot of learning we can do. And in nutshell, all this corresponds to reducing elder abuse. So thank you very much for this
Professor Maya.
opportunity to clarify.
Absolutely. In fact, this is a good platform talking about aging Asia. In this, I think we should congratulate Professor Dhananjay and Professor Shashank to bring all of us so that what commonalities that exist across different countries, what are the best practices which can be taken up by other countries from the countries which are experimenting and providing will be a very good. I'm sure Professor Dhananjay, we can take it forward in bringing out the outcomes from these proceedings, which will be a very good experiences and learning opportunities for the policy makers and program implementers. So I hope, I think with this, we will be winding up this session. Thank you so much, Professor Sekhar, Professor Mala Kapoor, for your own, experiences in highlighting the healthcare policies and also the ageism and elder abuse issues. And I think this is a very good session that we all experienced and contributed. Thank you so much. Now over to Professor Dhananjay.
Yeah, thank you so much, sir, for conducting such a wonderful sessions with your experience and all those knowledge. You have conducted this session very nicely. I must thank both the panelists, Professor T.V. Shekhar as well as Mala Kapoor, for their very good talk. So, and as you mentioned that we are just bring out these all the discussions in a publication form. That is also in our idea that after these sessions, we are also asking the final papers and we are trying to bring it out as a 1 or 2 volumes if possible. And that will be very, very useful for the policy perspectives. So in that connection, so we'll how, and we're just moving forward. So thank you so much, sir, once again. And we'll have the another sessions. I must thank both the speakers as well. I also wanted to ask one question, but now it's already 3, so I'll discuss afterwards with Marla.
You can send. Ask the participants also to send emails. Yeah, thank you. Thanks a lot.
We'll close these sessions and we'll move to the next technical session. And for that, we have the chairperson, Professor Sriram Krupanidhi. I think sir is, Professor Krupanidhi is already here. So we'll start this session, technical session. So I hope that participants, the speakers are already joined here. Lavina Reddy,
Lavanya Reddy, Dharmavir,
Rajeshwar,
Rimpi,
Rimpi, and Hina. All are there? Okay, Lavanya is not there, so we can have. Okay, let me, before starting these sessions, let me introduce Professor Krupanidhi. Professor Sri Rama Krupanidhi is a retired Dean and Head of the Department of Biotechnology at Sri Satya Sai Institute of Higher Learnings, Andhra Pradesh. And sir is also very experienced and he has a lot of publication in his credit. So thank you so much, sir, for agreeing to chair these important sessions. So now, I'll request you to please continue the session. Thank you so much, sir.
Yes, thank you, Professor Dhananjay, sir, and others in the organization committee. And it is my pleasure to take this responsibility. And now may I call Dr. Lavanya Reddy. If she's not there, next speaker, Dharmavir Chauhan.
Yes, sir, I'm there. Yeah.
Okay. So Dharmavir Chauhan. Okay.
Yes,
you
sir.
Introduce yourself where from your. Please listen. Please listen. You introduce yourself where from you have come. What is your experience in a short span of half a minute? Then stick on to your time for nearly to 12 minutes. At the end of the 12th minute, I will remind you. By 15th minute, please stop. Okay. So now we are reaching the fag end of the day. Okay.
Okay, sir.
Thank you. Thank you. Proceed.
Should I share my slides?
Yes, please.
So, warm good afternoon to all of you. I am Professor Dharmavir. I working as assistant professor at Department of Microbiology and Biotechnology, DB Science College, Gondia, one of the prominent institution in Eastern Vidarbha region of Maharashtra state, India. My topic is study on antibacterial potential of common wild herbs against Staphylococcus aureus from mastitic cattle. As you are very much aware about the mastitis disease, actually mastitis is an inflammatory disease of the mammary gland, which is very much prominent among the cattle. In India, at present, at national level, there is not any national program is available for controlling the mastitis disease. And due to that reason, large number of cattle, they were get infected with mastitis annually. And there was a large loss takes place. And the major cause of mastitis in the cattle is a Staphylococcus aureus, which is belonging to the gram-positive bacterial class. And these bacterial pathogens causing the mastitis, if not treated properly, in that condition, these mastitic causing Staphylococcus aureus getting resistance to the antibiotic, and these drug resistant or antibiotic resistant Staphylococcus aureus are easily get passed from milk through the milk from infected cattle to the human beings. And that particular drug resistance transfer leading to causing several health hazard to the consumer human individuals. So with this particular initial background information, we plan a research project to conduct in our laboratory, in which we initially selected some gaushalas from the Gondia city, from where we collected 12 samples from the mastitic infected cattle of different age group. The age group of this cattle is from 2 to 8 years age, and most of these cattle are at the clinical state of infection. After collecting the pus samples from these infected cattle, we isolated the Staphylococcus aureus, the major causative agent, by the sprayed plate technique on bared Parker agar. These isolates were maintained in the laboratory on nutrient agar slants. After isolation, we perform the identification based on morphological, biochemical, and cultural characteristics. When we subject these isolates for antibiotic susceptibility testing by disk diffusion method, as per the NCCLS standards, it is found that out of the total 12 isolates of Staphylococcus aureus, majority of the isolates were found to be antibiotic resistance. And the resistance profile of these particular isolates is as per below. Out of these all isolates, the 100% isolates were found to be resistant to amoxicillin, cannabamycin, methicillin, these antibiotic. 96% isolates were found to be resistant to penicillin G. 92% isolates were found to be resistant to ceftazidime. 88% isolates were found to be resistant to nalidixic acid. So it shows that most of the isolates were found to be highly resistant, and these resistance indicating that due to the subclinical or due to the sublethal concentration of the antibiotic given to these cattle, leading to the drug resistance. In India, as we are knowing that large number of individuals does not having the great awareness about the use of the antibiotic. If the recommended dose of the antibiotic is 100 micrograms for curing a particular infection, in that scenario, only 40 to 50 micrograms of the dose actually humans are consuming, And in case of the cattle, that particular awareness is also goes on a declination level. And due to that reason, sublethal dose administration to curing the antibiotic, leading to development of the antibiotic resistance among the cattle. Staphylococcus aureus. Same scenario we are observing here. Against these particular antibiotic resistance isolates of Staphylococcus aureus, to treat these drug resistance S. aureus, we are found to develop the herbal therapy from locally available some herbs. We commonly choose 4 herbs. One is Ocimum sanctum, another one is a Tridex procumbens, next is Solanum sanctum, Argemone mexicana, and 5th one is a aloe vera gel. The initial 4 plants were collected in the form of plant leaves. Their powder is prepared and 10% aqueous extract is prepared in the water. While from the aloe vera leaf, we are directly collecting the gel, and the aqueous extract of the 4 initial plants and the gel of the aloe vera is subjected for antimicrobial activity testing. Out of the all drug resistance pathogen selected, 100% drug resistant or antibiotic resistant Staphylococcus aureus strains were found to be susceptible to Ocimum sanctum. 90% isolates were found to be sensitive for Tridex procumbens. 90% pathogenic strains were found to be sensitive for Solanum sanctum. 40% were sensitive to Argemone mexicana, and 10% were found to be sensitive for the aloe vera gel. So it is generally this study generally indicating that as compared to the conventional antibiotics, the traditional available our local herbs, they are having the good antimicrobial activity in even aqueous form. And if we are giving these herbal formulation in to treat the mastitis in the cattle, it become low cost or cost effective antimicrobial therapy against mastitis causing Staphylococcus aureus. A conclusion is there. Emergence of antibiotic disease, emergence of mastitis disease is very, very common in the rural region of the India. Actually, in a rural region, there were the farmers mostly does not affording the antibiotic treatment of the mastitis like diseases, and due to that reason, they are only 1 to 2 doses administered, and due to lethal concentration administered to the cattle, the antimicrobial drugs or antibiotic, they are developing. They are found to be cause to lead development of the antibiotic resistance among the pathogens. So treat such drug resistance pathogens nowadays. Formulation of the herbal component is one of the important choice to treat such kind of the diseases. And in our study, Ocimum sanctum is found to be effective drug against pathogenic microorganism. So I conclude that herbal therapy in the form of Ocimum sanctum plant or Ocimum sanctum leaf is one of the effective treatment to treat these kinds of the diseases such as mastitis. Thank you, sir.
Thank you, Dr. Dharmavir. Nice talk on mastitis, which is very important. Particularly the cattle are suffering with this mastitis. And not only the cattle, even milk also, there is same infection being carried out. So it's better to be cured at the root level. Thank you. If any questions are there, please put in the chat box. We'll seek his opinion at the end of the session. Thank you, Dharmavir.
Thank you, sir.
Next, Dr. Rajeshwar Reddy. Is there Rajeshwar Reddy around?
So he's not there, sir. We can move ahead further.
Next Dr. Lavanya Reddy.
No, she's not there.
Okay, Dr. Rimpi Kaur Chauhan.
She
Dr.
said
Rimpi Kaur Chauhan.
we can move on to Hina Bansal.
Okay, thank you, ma'am. So, may I now invite Dr. Hina Bansal. Dr. Hina Bansal.
Yes, sir, I'm there. Just give me a moment. I'm sharing my
Yeah.
presentation.
Yeah. So, meanwhile, shall I interact with Dr. Dharmavir? It's not there. Okay. Dr. Hina, please introduce yourself, where from you are, and then start your presentation. At the time of 12th minute, I will remind you so that you can go fast and complete within 15 minutes.
Yes, sir. So I hope my presentation is visible to you all.
Yeah, visible, audible, both are fine, madam.
Okay. So myself, Dr. Hina Bansal, I am assistant professor in Amity University, Noida, and I would like to thank the organizer to give me the opportunity to present my work entitled Unveiling Therapeutic Opportunities, Subtractive Genome Analysis of Providencia Stewardty for Drug Target Identification and Epitope Mapping. As Providencia stewardty is a gram-negative pathogenic bacterium associated with various types of infections in human, specifically in immunocompromising situations such as urinary tract infection, wound infection, respiratory tract infection, and blood infection. And it is known for its multi-drug resistance. So the current research used a subtractive genome analysis that approach to identify essential enzymes that are unique to the pathogen and can be used as a potential drug target against its pathogenesis. The subtractive genome analysis is a powerful approach in genomics, enabling researchers to focus on specific genetic differences that may have significant biological implications. It will provide a foundation for developing new therapeutic strategies against the pathogen, which poses significant challenges due to its resistance to multiple antibiotics. So the research objectives of the current study are to enhance the understanding of Providencia stewardty and uncover novel therapeutic avenues for addressing infections caused by this opportunist pathogen, and can be outlined as identify unique genetic elements. It is by utilizing subtractive genome analysis, one can pinpoint genes and genomic regions that unique to Providencia stewardty, especially those related to pathogenicity and antibiotic resistance. Next is characteristic potential drug target. This is the analyze the unique genes identified for each potential as drug target, focusing on essential genes that are conserved across related pathogens but absent in the host. Then evaluate functional roles. It is the investigation of the function to identify genes through in vitro and in vivo studies to assess their role in the pathogenicity of the pathogen. Then epitope mapping to identify and characterize epitope derived from the unique protein, facilitating the development of vaccines or diagnostics tools. Then develop therapeutic strategies based on the findings. Propose novel therapeutic strategies, including potential drug formulation and vaccine candidates, aim at combating infections caused by Providencia stewardty. So this is the methodology that can explain that we first extracted the metabolic pathways of the human and the pathogen from the CAC pathway database. Then manual comparison was done, and the pathways that are present only in pathogen will be considered as a unique pathogenic pathways, and the common pathways will be removed from the study. Then all the enzymes were extracted that are present in the unique pathway using the GapTop tool. The essentiality of those genes have been identified. Those genes which are shown essential to the pathogen are included in the study, and non-essential genes are eliminated from the study. Further, all the essential genes were subject to BLAST homology search and found homologous to the human host will be discarded, and only non-homologous protein which are not presenting any similarity with the human genome, these are included in the study. Then the PPI network was constructed using the string database. Then all the PPI network constructed for all the non-homologous essential proteins, and M-code analysis was conducted to find the hub genes, the cluster genes that are mostly related and having the highest rank in the highest cluster module. Then subcellular localization was identified, followed by the toxicity analysis. Then gene ontology analysis was performed, and finally the druggability testing was performed. All the genes which are having existing drugs, means the hits found will be discarded, and all the non-hit found proteins, their drugs are not found, selected as a novel drug targets. Then finally the epitope mapping was conducted and find using the ABC-PRED server. Then moving on to the result section, we find the KEC pathway database was employed to extract the metabolic pathway of the pathogen and the host. A manual screening was done to discover the pathway exclusive to the Providencia-S280. Metabolic pathways that were exclusively present in the pathogen were considered as unique pathway and assumed to be responsible for showing the pathogenicity in the host. A total of 93 metabolic pathways were extracted, out of which 28 were found to be novel to Providencia-S280 after manual comparison with host metabolic pathways. All the enzymes involved in these 28 distinct pathways were extracted and screened for their essentiality. A total of 298 enzymes were predicted to be essential for the pathogen and identified as non-homologous, as they did not show any homology with the human. Now these 298 non-host essential proteins were subjected to a string database and a PPI network was obtained. The most likely metabolic functional relationship between these selected proteins were determined by looking at the highest rank cluster module having 25 nodes. So these are highlighted in yellow color in the network. A protein-protein interaction network represents the physical and functional interaction between protein within a biological system. Understanding these networks is crucial for elucidating cellular processes and disease mechanism. The selected higher rank module, which is having 25 protein, was subject to gene ontology analysis. Here you can see in the gene ontology analysis, we can find that in biological process, 30% proteins are involved in lipid A biosynthesis, 25% proteins are involved in peptidoglycan biosynthesis, 23% proteins are involved in liposaccharide biosynthesis, and only 22% proteins are included in cell division. When we see the molecular function, then 48% of the proteins are APT binding, 25% are involved in transferase activity, 15% proteins are involved in kinase activity, and 12% proteins are involved in carbohydrate derivative binding activities. When looking for the cellular component, then we see most of the proteins are cytoplasmic. At 88% proteins are present in cytoplasm. Then 8% of the proteins are membrane protein and 4% are the other proteins. Now we check the druggability and toxicity testing. A novel drug target identification was performed using the drug bank database. Proteins that displayed no matching hits against the standard cutoff value were proposed as novel drug targets. Toxicity analysis revealed that none of the proteins were toxic in the nature, and the result revealed these 15 proteins as novel drug target, as they were specifically involved in unique pathways of the pathogen. These are listed in the table. And followed by beta cell epitope mapping. So beta cell epitope mapping was done by artificial neural network ABC-PRED program, which indicating these 3 proteins which are present in the membrane and having the score greater than 0.9, considered as a vaccine candidate. Now we can summarize our work in this figure only, which is showing a total of 1084 protein. We find 358 as an essential protein, out of which 298 are non-homologous protein, in which 25 are having functional association, and out of which 15 can be suit as the best novel drug targets and 3 proteins as a subtractive genomics. So the identification of the key findings can be the identification of several potentially drug targets that are unique to the pathogen and are not present in human. These targets could be important for developing new antibiotics or therapeutic agents. Then identifying these unique drug targets help develop antibiotics that specifically target pathogen without affecting the host. Epitopes, specific epitopes were identified that could be used to design vaccines or diagnostic tools, and this can aid in creating vaccines that elicited the strong immune response against the pathogen. Now, when we are moving to the conclusion, so in conclusion, we can summarize that the study aimed to address critical gaps in our understanding of this opportunistic pathogen. By leveraging subtractive genome analysis, we have identified unique genetic elements that could serve as potential drug targets and epitopes for vaccine development. The finding of this research not only contributes to the fundamental knowledge of Providencia-S280, but also hold promise for developing novel therapeutic strategies to combat infections caused by this organism. Further, experimental validation of the identified targets and epitopes is needed to confirm their efficacy and safety. Future research can build upon the foundational work laid out in this study, ultimately leading to effective intervention against Providencia-S280 and enhancing our ability to combat opportunistic infection more broadly. Thanks for your attention.
Thank you, Dr. Hima, for the wonderful talk on the bioinformatics session, particularly on epitopes and also subtractive genome analysis. Very interesting. Really, I felt quite happy when you were mentioning about the epitope mapping and all that. But one thing, why did you not test it with HLA2 mapping? Directly, you were telling B cell mapping.
Yes, sir.
HLA2 binding, you have to, so for all bacterial proteins, you have to bind, you have to see the binding potential to HLA2, no?
Sorry, sir, your voice is not clear to me.
No,
Can you repeat your question?
the binding potential of the epitope sequence to that of the HLA2 is almost mandatory to evaluate its epitope potential, no?
Yes, sir. Yes, sir. This is our future. This work is still going on, sir. And we will definitely consider that point which you have suggested. And we'll definitely go for it. We will check the binding affinity. Yes, sir.
Yeah, it is sequential epitope, madam, or is it, there are epitopes which are sequential, there is some other epitopes, no? Is it sequential
Yes,
epitopes? Yeah.
Yes, sir. These are sequential episodes.
Allergic test, did you do? Toxic
No,
test
sir,
you have done?
that still we haven't done. So we will moving forward for that part also.
Yeah. So you have come down to 28 novel metabolic pathways.
Yes,
that
sir.
includes even even shikimate pathway.
Sir,
In
these
bacteria,
pathways are. Sir, I can show you the list of the pathways. It is there with my supplementary file. If you want to see the list of the pathways, what are the basic pathways? So I can. Yes,
no
sir.
problem.
I
Shikimate
can
pathway is very popular
share.
among the shikimate. Okay, no problem. It's good
Sir,
talk.
I'm not
Thanks.
getting your point.
Shikimate pathway is popular among the
pathways.
that is popular
Okay.
among bacteria, but not in humans. So all the drugs are being directed against the shikimate path.
Yes, sir. Yes, sir.
That's what I'm asking, whether this shikimate pathway, does it include out of the 28?
Yes, sir.
What
Yes, sir. Yes, sir. Yes, sir.
Yeah, that
These are
also
included, sir.
Thank you, ma'am. Thank you for the wonderful talk.
Thank you, sir.
We also have published a good many papers on him. You can have a look at it. Thank you. Thank you, Dhananjay sir. Only 2 are there in my session.
No, we have one Rimpi, and we can take
Rimpi,
more Madhurima from the next session.
Rimpi is there?
Yeah.
Dr. Rimpi, madam?
I hope I'm audible.
Yeah, now you are audible. You are, you are visible, audible. Now
Right.
put
Thank you
the
so
slides,
much.
madam.
Yeah, sure, sir. I'll just
PPT.
start presenting. Yes, sir. Give me a second.
Rimpi, madam, little louder. Your
Yeah.
voice is very,
Will
very
it
low.
be will it be fine now?
Yeah, now it's fine.
Sure.
So introduce yourself. Where from are you? Then
I hope my screen is visible to everyone.
Yeah.
Okay. Hello, everyone. First of all, I would like to congratulate the panel and organizer for organizing such a beautiful workshop and symposium. And I want to thank also everyone for giving me an invitation over here. Today I'm going to talk about exploring the impact of SARS-CoV-2 virus infection on amyloidosis development. I'm Dr. Rimpi Kaur Chauhan, Assistant Professor at Department of Biomedical Sciences, Acharya Narendra Dev College, University of Delhi. We and our team in our college are kind of exploring how cardiac amyloidosis basically is affected. Now, first let's get and understand about what is amyloidosis. We all know it's a disease which is characterized by accumulation of misfolded or aberrant proteins in the form of amyloids, which hampers the functioning of the normal cellular physiology as well as causes toxicity within the cell. Over the years, we have realized with the help of various experiments done in humans and mice that it is an age-related phenomena as well. To that extent that we consider it as a universal disease of aging. So as the age increases, amyloid accumulation has been seen to increase with multiple folds. What causes this amyloidosis is considered to be or attributed to be majorly the mutations within the proteins, which ultimately leads to production of misfolded proteins, which keeps on getting accumulated over the course of time and enhances the generation of what we currently know as amyloidosis phenomena. These kinds of diseases occur in your brain tissues, cardiac tissue, as well as various other parts of the body, which you cannot even consider. Like, for example, insulin aggregation leading to diabetes is also commonly known now because of the amyloidosis phenomena. So, which brings us back to the recent past, we have seen emergence of viral disorders. That viral disorder was SARS-CoV-2, COVID-19. The whole world was impacted by it. And when I say the whole world, it is also an age-dependent phenomena. And we saw a majority of elderly or senior citizens were also majorly affected by this disorder. And over the course of time, the various studies came up which have shown that SARS-CoV-2 infections, in fact, is kind of leading towards in those cases, or maybe in the cases of long COVID, or in the patients which have been infected, has shown no particular genetic history of amyloidosis formation, was also showcasing presence of amyloids or presence of protein aggregates within their body, which led us to the belief that maybe this particular viral infection has a role to play in amyloidosis. For the sake of understanding, we restricted our preliminary studies on cardiac amyloidosis. We first wanted to understand maybe what's happening over there. Now, first of all, let's understand the mechanism of SARS-CoV-2, how it enters our cell or our body. It utilizes the major surface proteins involving spike protein, envelope proteins. It interacts with majorly ACE receptors present on the surface of our cells, enters inside our body, releases its genome, and the genome is then utilized to create its own protein and carry out the lytic cycle that we know about. Now, there were other studies which were coming in as well. These kinds of studies were showcasing, in vitro studies which were showcasing, or some scenarios, bioinformatics studies which were showcasing that these spike and envelope proteins was found to interact with serum amyloid A, another serum protein, and was leading to formation of, or had the capacity to form, amyloid fibrils from this particular protein. At the same time, downregulation of ACE2 receptor and upregulation of spike proteins within the lungs were, after COVID infection, was found to lead to formation of amyloidotic microclots within the vessels. On the other hand, there was a large pool of cases coming up that in the long COVID, there were accelerated rates of amyloid formation. And then we also saw that after vaccination, certain individuals were showing large amount of clot formations and protein aggregation, which led us to an hypothesis. We believed that because we know that amyloidosis generally happens or starts because of the structure being affected. It's the gene mutation leading to the misfolded protein leading to amyloid formations. So maybe, and now we know so far that certain amount of proteins, of surface protein specifically of virus, has the capacity to interact with human proteins. So maybe there is a direct cause and effect relationship of this interaction, which is leading to certain proteins becoming more amyloidogenic in nature. So let's understand this biochemical mechanism, because we do have a large amount of, already within our body, we have a large pool of proteins which are aggregation prone, or we refer it to as amyloidogenic in nature. So we started our study. We first took up spike protein, envelope protein, membrane, and nucleocapsid protein. These 4 proteins are present on the surface of the virus. Then we scrutinized the viral proteins. Then after that, we scrutinized our human cardiac proteins, which are already known to participate or have been seen to form aggregates or amyloids or amorphous aggregates in the case of cardiac amyloidosis in patients and leading to fatality. So in general, we knew any kind of mutation or any kind of trigger within these proteins is bound to trigger a large amount of reaction. So ideally, in a normal person where their genes coding for this protein is perfectly wild type, amyloidosis never occur. Only in the patients where the gene coding for these human proteins is mutated or because of XYZ features which leads to aggregation or changes the structure or leads to misfolded in the protein can only trigger amyloidosis among these proteins, otherwise not. So we wanted to understand, maybe there's a chance that if the viral proteins are interacting with these human cardiac proteins, then are they also increasing the aggregation potency of these particular human cardiac proteins? So to understand all of this, we carried out a bioinformatic analysis. We explored all the potential interactions between SARS-CoV-2 structural proteins and human amyloidogenic cardiac proteins and assessed the potential role of these interactions influencing the amyloidogenicity of the cardiac proteins. So the first thing we did was we carried out a preliminary docking studies. We tried to understand what all possible interactions could be there. So we had 9 human cardiac proteins, which we had narrowed down to. We tried to interact. We see other interaction with the 4 surface proteins of the virus, and we found, to our surprise, that all amyloidogenic cardiac proteins were showing good amount of binding energy or binding interaction towards the viral structure proteins. And in fact, if you look at the B category, that was the binding interface, even the interface area was pretty large to not consider them as something which is to be taken seriously. The other interactions, hydrogen bonding, ionic interactions, and van der Waals interactions were seemingly high as well in majority of these. Since in comparison to spike, membrane, and nucleic acid, envelope protein was the one which was showing strong interaction with all of them. While in the case of spike, we can see it was not strongly interacting with gel. So there were certain cases where the interaction was not found. Envelope, on the other hand, the envelope viral protein was showing strong interaction with all the cardiac amyloidogenic proteins. So we then, just to understand or have a better understanding of this particular interaction and also investigate the stability of the dock complexes, we streamlined our study to investigate the interaction between the monomeric form of envelope protein and human cardiac proteins. Why particularly monomeric? So envelope protein can exist in both multimer and monomer formation, and all the forms have been shown in the past to perform or being equally important and present in equal amounts on the surface of the viral protein. And utilizing a monomer protein allows us to have a better understanding of what is happening in terms of interaction within our protein, considering it's a in silico study. So we again carried out our interaction studies with the monomeric envelope protein. As seen earlier with the multimeric as well, the monomer was also found to show good amount of interaction, very large negative binding energies, solvation and electrostatic and van der Waal interactions were also pretty high. So basically showing that all the amylogenic cardiac proteins were spontaneously willing to bind with monomeric form of the envelope protein. We then carried out the simulation of these complexes. After doing that, we found the RMST profile was stabilized after the 10 nanoseconds for almost all of them, showcasing that the stimulation performed was done in an efficient manner. After the simulation, the pre-simulated and post-simulated interaction, the interface area, in fact, was found to be enhanced, showcasing that the docked structures which have been earlier found, they were highly stable, and that's why even after simulations, they are still stable, they are still showcasing interaction among each other. Then our next goal was to understand how this interaction is affecting the structure of the human cardiac proteins. And we saw that the solvent accessible surface area was found to be, almost like, for example, in the case of apolipoprotein A1, it was found to be almost normal. ANP in fibrinogen was found to decrease. So we were looking at, so what happens is, we have your hydrophobic amino acids within the core of the protein, and hydrophilic amino acids are generally on the solvent area, near the solvent on the outside. This kind of conformation, majority of the time in case of monomeric proteins, allows the protein to remain stable and not aggregate. Now, when the proteins start opening up, their solvent accessible surface area starts increasing. That implies that the protein is opening, or the structure is changing or altering in a very different manner, where it is now has more access to solvent. When that happens, it also inclines us to believe that maybe the change in the structure is to that can lead to opening up of the structure in a format that the hydrophobic amino acids are getting exposed to solvent. And that is never a good thing in cases of if any possible interaction is not in the vicinity in the phenomena. Because the moment your hydrophobic amino acids are exposed to the polar solvent, they don't want to undergo that interaction. To bypass or to get safe from that, they will prefer, in fact, to interact with another protein with, and form a hydrophobic interactions with them, which leads to an ordered formation of one protein interacting with another. Earlier, they were not supposed to. Now they're doing it, leading to multiple proteins doing the same phenomena of interacting with each other.
Please complete.
Okay, leads to the formation. Yes, sir. 2 minutes more. Leads to the formation. Yes, sir. I hope I'm audible. Just 2 minutes more, sir.
Thank you.
Okay. So leads to the formation of protein aggregates. So in the case of this particular case, we found atrial natriuretic peptide in fibrinogen alpha to in fact increase in the SASA. So ANP in fibrinogen alpha was recognized to have that structure altered to a very larger case. Similarly, we also analyzed the hydrogen bonding profile and found that apart from gelsilin and transthyretin, almost all of them were showing strong hydrogen binding interactions. And ultimately, we checked whether, because of the changes in these structures, is there an enhancement in aggregation propensity? And we found apolipoprotein A1, gelsilin, ILH, transthyretin, and beta microglobulin. All 5 of them were showing huge change in the structure, which were leading to the aggregation propensity being enhanced. So these are all wild type proteins, which after the interaction with surface proteins of the virus were showcasing huge change in their structures, and also quite a high escalation in their aggregation propensity as well, which leads us to have a confidence that maybe if we look into these studies in vitro and in vivo, it will give us a better idea about the mechanisms of how protein amyloidosis takes place in general, and how we can in fact model these kinds of, with the help of viral infection, we can model these kinds of studies within the mice and others and study amyloidosis without wasting a lot of time in creating an age-related model. I thank all of you and the principal and my collaborators, Dr. Rachna Pandey, DBT Star College, and our mentors. Thank you very much for giving out your time. If you have any questions, let me know.
Thank you. Thank you for the nice presentation on the bioinformatic tools, particularly using the SARS envelope proteins on amyloidogenesis. Very nice talk, madam. Thank you. So, Dr. Dhananjay sir. Dhananjay sir is not here.
Yeah, I'm there.
Yeah. So shall we have one more, sir?
I think
in this
we'll have
session?
one more presentation by Madhurima.
Okay.
Yes, she's supposed to present in the next sessions. Since two people are not there, so we just prepone her present. Yeah.
Okay, Madhurima. Dr. Madhurima,
Yes.
madam, are you
Yes,
here?
sir.
Very good.
Yes, sir.
Thank you. Let's start.
Okay, so I'm sharing
Please complete within 15 minutes.
Sure,
Okay. By about 12th minute, I will remind you. Please introduce yourself.
Okay. So first I'm sharing my PPT.
Carry. You are audible, you are visible, both.
Okay, sir. PPT is visible, sir? My PPT?
PPT, yeah.
Okay, sir. Hello everyone, myself Madhurima Sharma and I am a PhD scholar at IIPS Mumbai. Thank you for giving me the opportunity to present my research work here. And so today I'll be presenting and talk about, one second. Yeah. Today I will be talk on the topic basically the wealth disparities and cognitive impairment among the elderly in India and analyzing the contributing factors. So let's go to the background. As you can see here, as people age and India's population is aging and overall the world is also aging. Age-related health issues are significantly increasing with the aging process. So in India, the geriatric population is expected to increase around 19% of the India's total population by the year of 2050. So as people age, it is natural for some cognitive abilities to gradually decline. This is called cognitive aging. It is a normal part of the aging process. But on the other hand, the cognitive impairment goes beyond the normal aging. It involves significant decline in cognitive abilities, like which affecting memories, decision-making power, and other performing the daily activities. So cognitive impairment is one of the major severe public health concerns of the 21st century among all the known psychiatric disorders. As worldwide, around 55 million people have dementia, with over 60% more living in the lower and middle income countries. So, here in the study, we have measured the cognitive impairment through 5 broad domains. These are, first one is memory, second one is orientation, arithmetic functioning, executive function, and object naming. And after combining all the 5 domains, we got a composite score ranges from 0 to 43. And the higher the score, which indicating the better cognitive functioning among all riders. And we have divided it in 2 parts. First one is those who have got the score lesser than 10 percentile. They have been classified as cognitive impaired. And second one, those who are scored more than 10 percentile, they have been classified as non-cognitive impaired. So let's come to the objectives of the study. First one is to assess the prevalence and determinants of the cognitive impairment among elderly ages 60 and above in India. And second one is to measure the socioeconomic inequalities in cognitive impairment among elderly and determine the contributing factors to the inequalities. Next one is, here I have used for the study the LASI data, longitudinal aging and study in India, wave 1 data. And the present study is based on the eligible respondents aged 60 years and above, which is the sample size, the main sample size is 31,464 riders. So these are the outcome variable of these are the study variables of my study. First one is the outcome variable. The outcome variable, we have taken the binary outcome variable, which is cognitive impairment. 0 as not cognitive impaired. Second one as a having cognitive impairment. An explanatory variable, the main explanatory variable was economic status, which has been measured through MPC, monthly per capita expenditure, which is computed as the summary measure of consumption of the household, and this has been divided into quantiles. Quantile 1, which is indicating the poorest, and quantile 5, which indicates the richest. And other exposure variables has been classified in demographic, socioeconomic, social support, and health factors. So let's come to the statistical analysis. For objective 1, we have done bivariate analysis to measure the prevalence rate of all the socioeconomic, demographic, and health factors, and chi-square test has been used to take the intergroup differences in the prevalence of cognitive impairment among elderly. And binary logistic regression has been used to estimate the effects of demographic factors and different predictors on the cognitive impairment among older adults. So in the equation, you can see in the above equation, x 1, 2, and 3 are the predictors, and a is the intercept, and b beta 1, 2, and 3, and up to beta n are the regression coefficients. So for objective 2, now we have computed the concentration index and concentration curve have been measured. First one here, the age in the equation, you can see here the age is the health outcome, and mean is, mu is the mean of the equation. And second one is the work steps decomposition analysis has been performed to assess the contribution of each factor to the inequality. And so let's go to the results. In this table, you can see that more than half of the participants are female in this survey, and around 61% of them are currently married, currently in a union, and about 70% of the participants are residing in rural areas. And among them, about 30% of the older adults have reported they have depression, and around 76% have reported that they don't have any difficulty in ADL, means the activities in daily living, and about 48% among them have reported that they are facing difficulties in doing their instrumental activities in daily living, like cooking, dressing, and different instrumental activities. So this is the prevalence of cognitive impairment by demographic, socioeconomic, and health determinants. And you can see, compared to male, female have much more higher prevalence rate of cognitive impairment, and those who are currently married, they have lesser prevalence compared to those who are not in a union. And in terms of caste, you can see the ST population is much more at risk in terms of cognitive impairment. And in case of socioeconomic determinants, you can see those who have no education, they have much more prevalence rate of cognitive impairment compared to others. In this diagram, you can see we have shown the prevalence of cognitive impairment among elderly persons across the states of India. You can see that here that the eastern region and northeastern part of the states have reported the higher prevalence of cognitive impairment among older adults. And in case of male, in the diagram you can see here, in the northern part and the western part, it is showing the higher prevalence of cognitive impairment. But in case of female, it is showing in case of Andhra Pradesh and Bihar and Jharkhand area, it is showing the higher percentage of cognitive impairment among elderly women. So the binary logistic regression results are showing here that the females are much more vulnerable in terms of cognitive impairment than male, and as discussed here, and those who reported their health as a poor, self-rated health, they have been rated their health as poor, they are much more vulnerable to the cognitive impairment. And in case of social groups, as we can see, compared to those others, the scheduled caste and scheduled tribe population are much more at risk of this cognitive decline. So we can see in this here also, those who are receiving financial support, they are at lesser risk in terms of cognitive impairment. And in education level also, we have already shown in the previous diagram. So next, here you can see the concentration curve of cognitive impairment. The slide shows the concentration curve. In the x-axis, it is showing the cumulative percentage of population ranked by economic status, and in y-axis, it's showing the cumulative percentage of cognitive impairment. So the concentration index value is showing that the minus value, minus 0.118, which quantifies this inequality. The negative value confirms that the cognitive impairment is concentrated among the economically disadvantaged, and the red line is showing the line of equality, and which shows that the gap between the observed curve, the concentration curve, and the equity is larger. So it's showing that the poor, they are much more vulnerable towards the cognitive impairment. The decomposition analysis I have done here. First one is showing that mainly the place of residence is playing a major role. It is showing 80% contribution towards the inequality of wealth inequality and cognitive impairment, as well as, and you can see mainly the educational level, which is 31%, is showing the highest contribution towards the main inequality of cognitive impairment among all riders. And financial support is showing 12% of contribution, and living arrangement is also showing 0.6% of contribution to the inequality. So these are the major findings of my study. First one, in the study observed that the prevalence of major cognitive impairment is higher among females than males, and it is concentrated among the elderly, those who are from lower economic background. Depression in old age significantly impairs the cognitive functioning among elderly, which is negatively affecting their mental acuity. And next one is the rural backgrounds estimates with a higher prevalence of cognitive impairment among them than the urban areas. And elderly individuals who have no education have a significantly higher prevalence rate of cognitive impairment rather than those who attended school or higher education. So these are some limitations of my study. First one is that this is a cross-sectional study, which limits us to draw any causal inferences from the findings, and in last dataset have relied on self-reported measures which may lack accuracy and potentially introduce some informational bias, and the exclusion of samples with missing information that may complete case analysis introduce potential bias. So adapting quantitative approaches may offer additional insights in future researches, and this is essential for a more comprehensive understanding of the observed associations in the study. In conclusion, I would like to conclude by saying that the study shows evidence that the elderly, those who are economically vulnerable, they are basically poor elderly, much more likely to develop cognitive impairment. They need much more attention, giving more focus on some specific groups, including elderly women, widowed elderly, and those who are illiterate, and among the individuals without any financial or social support. We have recommended here two strategies. First one is first strategy will promote the education coverage to introduce accumulated socioeconomic gaps in old age. And second strategy I will be mentioning here, that is to improve the overall care of the elderly persons by developing healthcare programs and facilities by decentralizing the healthcare delivery system. And the community awareness also should be increased. Thank you. Thank you.
Thank you, Madam Madhurima. You are just within the time. Nice presentation on cognitive impairment, socio-economic inequalities, and healthcare aspects. Thank you.
Thank you, sir.
Thank you. So, Dhananjay sir, shall I conclude?
Yes, sir.
Yeah. So, this is technical session 5 in this virtual symposium on longevity and health. Very nice presentations have gone through. The first one on the mastitis, which is very important topic, particularly in the villages. And the mastitis frequency is getting increased. As a result, milk is also getting, what is it called, contaminated through bacteria. He has done good work making use of the herbal therapy. The next topic was given by Hima Bensel on the bioinformatics. Very interesting topic, particularly on subtractive genome analysis. The other topic was given by Rimpi, that is on amyloidogenic proteins interacting with SARS surface proteins, particularly amyloproteins and others. The last talk by Madhurima Sharma, very nice talk, present talk on the cognitive impairment and socioeconomic inequalities and healthcare requirement for the elders and all those things. She spoke on a sociology basis and population-based studies. The first two are on bioinformatics. One is specifically on biology. The third one is on population studies. Thank you, and also. Thank you, Dhananjay, sir.
Thank you so much, sir, for conducting this technical session so smoothly. So initially there was some kind of hiccups, but afterwards we could manage to solve those issues. And initially there were only one or two presentations there. But subsequently we added one more presentation. So this technical sessions we could manage properly, and all credit goes to you, sir. Thank you so much. And I think since it is already 4 o'clock, so instead of just giving break, because instead of just going very late, so let us start another session as well, because the next session chairperson, Dr. Varalakshmi, is already there. Madam, are you there?
I'm here.
Yeah, so I think better we'll just start this another next sessions as well, technical session number 6. And that session will be chaired by Dr. Varalakshmi Manchana. And this Varalakshmi Manchana is an assistant professor at the University of Hyderabad, India. She completed her PhD from Rajiv Gandhi University of Health Sciences in Ages within Indian Nursing Council. Her research interests includes aging and health, adolescent health behaviors, NCDs, women's health, child injuries, and social behavioral health with the gender lens. So thank you so much, ma'am, for kindly agreeing to chair this particular session. And in this session, we have, so I think, 7 to 8 presentations. So I hope that will be very hectic for you, but I'm sure that you will be able to manage this. So I now request you to kindly chair this session. Over to you, ma'am. Thank you.
Okay. Thank you, Professor Dhananjay, for your invite to me to be part of this, as well as your kind introduction as usual. And Professor Dhananjay, before I start up, I have a query. Is the list shows 10 presentations, and did anybody finished earlier? Do we have how many now?
Yeah, Madhurima Sharma, she has just done just now.
So we have 9, right?
Yeah, we have 9. Out of this 9, I think 2 or 3 people only joined so far.
Okay.
So let us say, yeah, in between people may join.
Okay. So thank you. Before going forward, so this session includes looks like the last technical session, as well as little longer technical session, having 7 to 8. So all of you are, I'm expecting all of you are patient enough to bear with, and I welcome all the presenters also. And the session looks like it is a combination of combination, like somebody is presenting about the quality of life, as well as social and gender disparities, happiness and cognition, and also some of the therapeutic strategies. So I welcome you all, and shall we start? Before starting, I would like to say that each presenter has 10 minutes time. Please stick to your time. So the next presenter will be waiting for their turn. So let us take the questions by the end if somebody has. In case if it doesn't have, they will be posting their questions. So you will be forwarded and to share their answers later on. So please, shall we move on with the first presenter, Paramita Majumdar. Is available?
Madam? Yes,
yes.
Ma'am, am I audible?
You are audible. Please share your screen, and your presentation is for 10 minutes.
Yes.
Please go ahead. Please go ahead.
Ma'am, I hope it is visible.
Yes, it is visible. If possible, make it a slide more. Otherwise, please continue.
Yeah. So, good evening, everyone. At the outset, I'd like to convey my regards to the organizers, the esteemed panelists. So, I am Paramita Majumdar, and I am a PhD fellow in International Institute for Population Sciences, Mumbai. Today, I'll be presenting on my topic. It will be a short presentation. It will be on regional variations and determinants of quality of life among older adults in India, insights from Lassi Wave 1. So starting with the presentation. So I'm not going to present any figures because it is very much well established that longevity has increased across the globe and aging is a global phenomenon. Rather, I can say that it is our global future. So the first thing that we have to keep in mind is that we have to fulfill the needs of our older adults. We have to fulfill the needs of this aging population. And the first step towards fulfilling these needs is to have an overall idea about their condition. So their needs can be various. The first, they can have some physical needs, some psychological needs, they can have some financial needs. Then there is safety concerns, there is social needs. So they have several kinds of needs. And there are several metrics of understanding those needs or understanding their needs and understanding their aging experience. But one important metric is quality of life. And as WHO defines, quality of life is an individual's perception or individual's assessment about their position in life, and very importantly, in the context of the culture and value system in which they live, and about their goals, expectations, standards, and concerns. So if you talk about India, India now has more than 100 million older adults, and the projected figure says it is going to increase in future. And along with that, there are multiple geographical regions in India: North India, Eastern India, Western India, etc., etc. And each of the regions, they have their own socio-cultural and economic, unique socio-cultural and economic environment which can influence the aging experience. So the objectives are very simple. The first objective is to get an idea about the quality of living or the quality of life of the older adults, and the various, what is the condition of the various domains of quality of life. And the second thing is to understand the factors that are associated with quality of life. So for data, we are using LASI Wave 1 data. It is as of now a cross-sectional data, and the study population is older adults aged 60 years and above. The final sample size is 30,507 older adults, covering the entire of India, several regions and all the states. Descriptive statistics are there to get an idea about the estimates of QOL. And in terms of statistical analysis, bivariate analysis and regressions have been performed, which were performed in Stata 16 software. Now, if we look at our main outcome variable, which is quality of life, which has been constructed based on WHO's guideline, which is called the WHO QOL BREF, which has 26 items. But since it is a secondary data set, there are certain data limitations. So we have restricted to 24. So the major domains are firstly the physical domain, having information about the activities of daily living, the energy level of the respondents, information about pain, sleep, etc. Then in psychological domain, we have self-esteem, spirituality, positive and negative feelings. Then there is social domain, containing information about friends and family. Then there is environmental domain, containing information about finance, safety. And along with that, we have two additional domains. One of their overall health, where we are using self-rated health, the variable. And the second thing is getting an idea about their life satisfaction. So, and we have several covariates or predictors, which there are some individual factors as well as community level factors. And along with that, we are also including two very important covariates. The first one is household decision making, and the second one is participation in various social activities. Now, moving on to the findings, we can see the graphical presentation of the findings, and we can see in all the domains there are certain regional variations present. So to summarize this entire graphical presentation, I can say that the overall mean or the overall average QOL or quality of life score is around 70, but it varies across regions. And if we see the domain, in physical domain, the highest quality of life score is with South India, and the lowest is with Eastern India. Similarly, in psychological well-being, we can see West India is outperforming all the other regions, and it has the highest average score. Then social domain, in social domain, we can see the Northeast India has the highest score and other regions are far below. Then there comes environmental domain. Again, Central and Eastern India have the lowest scores. And the additional domains, which include general health and overall life satisfaction, we can see that West India has the highest score and is far above Eastern India, which is the worst performing region in terms of this additional domain. So regional variation exists in all the domains of overall well-being, and this regional variation exists in the overall quality of life score as well. Now the second thing, the second set of findings, it is from the what are the factors that are associated with quality of life. So we can see that quality of life scores were relatively lower in females. In those who never attended school, or those who are not married, and those who are currently not working. The second finding is that quality of life decreases as age increases. And the third is that from a life course perspective also, it can be seen that childhood factors like childhood health is also significantly associated with one's quality of life towards the end of their life. And another set of findings is that with decision making and social participation, so when decision making or when the individual participates in intra-household decision making, his or her quality of life tends to increase. Similarly, when a respondent is participating in social activities, participating in games, sports, or participating in some social events, their quality of life tends to increase. And when we did the bivariate analysis of this decision making and social participation across regions, we found some similar results like quality of life. That intra-household decision making is highest in Northeast India, which also has one of the highest quality of life scores. Then again, social participation scores, although it is lower in all the region, East India has the least score and West India has the highest score. Similar results were also found in the bivariate analysis of overall quality of life score. So we can see there is some kind of association between social participation, decision making, and quality of life, which our regression results are also supporting. And so what can we infer from this result? The first thing is that since the regions are quite varied in nature because they have their own distinct socio-cultural context, the aging experiences of older adults varies. And when this aging experience varies, their quality of life also gets impacted throughout. So findings indicate that the distinct socio-cultural context of different regions significantly influence the aging experience of older adults. So this is an important finding. The second thing is that I also like to highlight some challenges of working with the quality of life variable. So we know that there are a large number of measures like successful aging, healthy aging, active aging, and then there is quality of life. And all of them have several cross-cutting domains. But what quality of life does is that it gives us a summary or a concise overview of the aging experience of the older population, and this is an advantage of quality of life. But we have to be very careful on what we are prescribing in terms of policy, because all these other measures are also existing and the domains often clash with each other. And if we see the domains, second challenge is that if we see the domains of various domains of quality of life, some domains are affecting other domains, means there is some interrelationship within the domain, like the financial domain may affect the health domain. So it can impact the regression results. And the third thing is that there is no standard procedure of implementing this WHO QOL BREF scale of.
Paramita, excuse me, please wind it up. Can
Yes,
you
ma'am,
conclude?
this is the last. Yes, ma'am,
Yes.
this is the last slide.
Please conclude. Yes.
Yes, ma'am. So there is no standard procedure for implementing this WHO QOL BREF through secondary data sets. And so there is a lack of comparable estimates. Estimates may vary from studies to study. And the last point is that the reference periods of some of the domains are different. For like for energy, it is taking information for past week. For some other variable, for the information is taken for past 1 month. So when the reference periods vary, it may affect the estimates also. So that's all. Thank you. So if
So
you have any
mute.
query, you can.
Thank
Yeah.
you, Bamita. So we have seen your exhaustive information from the last year about the quality of life, and that is also giving the insights to the other presenters and other also prospective interested candidate that the factors involving the regional differences can be a future research also. Thank you. So you can see the questions later on also after the end of the group discussion. Thank you for your presentation. Maybe you can stop sharing. You have done already. Okay, thank you. So we would like to invite the next presenter. If the Papai Burman is available, fine. Otherwise, we will take up the Sadananda. Papai Burman or Sadananda, whoever is available. Papai Burman is not available.
I think Sadananda is also not yet joined.
Yeah, Mr. Sadananda.
Yeah.
So you can share your screen and you can start your presentation is for 10 minutes. Please keep your time for 10 minutes. And any questions, you can be available at the end of the session to give your responses. Over to you. Please start.
Is my slides visible?
Yes, visible, and it is in slideshow also. Please do it. Start. You can go ahead.
So first of all, good evening, everyone. My name is Sadanand Karun, and I am a student at the International Institute for Population Sciences. I thank to the organizers for giving me an opportunity to present my work. So the topic of my presentation is: do female older adults live longer and happier life than males? An analysis of gender disparities in happy life expectancy. So before moving ahead, I would like to explain what does happy life expectancy means. So happy life expectancy is the average number of years after birth or at certain age X that one could expect to live in happiness under given age-specific mortality rates and prevalence of happiness. It is analogous to commonly used measure of happy life expectancy, healthy life expectancy. Happy life expectancy is a measure of is a summary life table measure that disaggregates total life expectancy into happiness specific life expectancies such as happy life expectancy and unhappy life expectancy. It is used as a measure to assess quality of life at population level. So in this graph, you can see that India has made significant improvements in life expectancy at birth for both males and females. Female were at disadvantageous positions in terms of life expectancy before 1980s, but they are now living longer than males. Females' longevity advantage or mortality advantage is well established through several studies. The increase in longevity has resulted in population aging. In a specific context of aging, females are more in numbers than males at age 60 and above, which is an effect of their mortality advantage. However, several studies focused on Indian elderly points out that females suffer more from chronic illnesses, depression, poor cognitive health, poor hand grip strength, and higher level of functional limitations compared to males, which ultimately diminishes their quality of life. So this context of female living longer on one hand, but suffering more from illnesses on the other hand raises a question that does higher longevity of females translate into a corresponding advantage in happiness, or whether females' mortality advantage is leading them toward unhappiness? In the purview of this question, our study aims to examine the gender disparities in life expectancy, happy life expectancy, and unhappy life expectancy among older adults aged 60 and above in India. So first of all, I want to mention that to estimate happy life expectancy, we need data on two domains, that is mortality and happiness. So for mortality, I have obtained the mortality rates from sample registration system, and for happiness data, the happiness prevalence rates were obtained from longitudinal aging survey in India, that is widely known as LASI. For happiness, I have taken the life satisfaction scores. So life satisfaction score is a set of 5 questions, which is responses of which are recorded on a Likert scale. So total life satisfaction score varies, ranged between 5 to 35. We have created a binary variable of happiness by grouping scores 21 to 35 as happy and 5 to 20 as unhappy. After getting the happiness rates, we have smoothed the prevalence to binary logistic regression model shown in this PPT. After getting the data on age-specific mortality rate and age-specific happiness prevalence, the average life table starting from age 60 to 85 plus age groups were constructed using Rievel's method, and thereafter the total life expectancy was disaggregated into happiness life expectancy and unhappy life expectancy. Thereafter, correlation analysis was conducted to examine the relationship between happy life expectancy and total life expectancy. We have also employed a decomposition algorithm to decompose the gender gap in happy life expectancy into mortality and happiness effects. So let's move to the results section. So these are the findings. First of all, in this bubble plot, the dashed blue line is the line of equality. So bubbles below this dashed blue line shows female mortality advantage, and bubbles above this dashed blue line shows male mortality advantage. The size of bubble shows the magnitude of gender gap. This bubble plot shows that the male and female life expectancy at age 60. So this bubble plot beautifully illustrates that female have mortality advantage as they are living longer than males at national level and in all states except Bihar and Jharkhand. Bubbles above the line of equality shows that male live longer than females in Bihar and Jharkhand. So this graph presents the state-wise smoothed age-specific happiness prevalence levels, where blue line represents males and red line represents females. This graph highlights the downside of female mortality advantage. We can see that female happiness prevalence is lower than males at national level and in most of the states. There are only 3 states such as Haryana, Karnataka, and Kerala where female happiness prevalence are higher than males at all age groups. Now, this table shows the estimated life expectancy, happy life expectancy, and unhappy life expectancy for both males and females. In this table, light green shading shows higher life expectancy for females than males, and light red shading shows higher expectancies for male than female. So, female have higher total life expectancy in India and every state except Bihar and Jharkhand, as we already discussed, and female have higher life expectancy at national level and in 15 states. There are 7 states, namely Andhra Pradesh, Assam, Bihar, Jharkhand, and Tamil Nadu, and Telangana, and West Bengal, where females have lower happy life expectancy than male in absolute years. And female have higher unhappy life expectancy at national level and all of its states except Karnataka. In Karnataka, though very minimal gap of 0.2 years, male have more unhappy life expectancy than females. So the expectancies discussed here are in absolute years. However, due to varying total life expectancy with state, it would be much better to assess the happiness-related expectancies in relative term. Therefore, we have calculated the percentage share of happy life expectancy and happy life expectancy to total life expectancy. For this, we have divided the happiness-related expectancies from total life expectancy and multiplied it with 100. Corresponding values are shown in the graph in next slide. So we can see that in this graph, the percentage of total life expectancy spent in happiness. So in this graph, we can see that the percentage of total life expectancy spent in happiness is highest in Gujarat for both males and females. Conversely, in Delhi, the percentage of total life expectancy spent in happiness was lowest for both males and females. Looking at the gender gap at national level, male spent 70% of their total life expectancy in happiness, whereas female spent only 66% of their total life expectancy in happiness. So different from absolute differences discussed in previous slide, we can infer from this graph that females spend less proportion of their total life expectancy in happiness compared to males at national level and in all states except only 3. 3 states, namely Haryana, Karnataka, and Kerala, are the only states where proportion of total life expectancy spent in happiness is higher among females than males. So this graph beautifully answers the question, does higher life expectancy translates into higher happy life expectancy? For males, The correlation coefficient value of 0.28 with a p-value of 0.19 suggests no significant relationship between happy life expectancy and total life expectancy. It means that states with higher male life expectancy are not the states with higher happy life expectancy. For females, the correlation coefficient of 0.34 with a p-value of 0.11 suggests insignificant relationship between happy and total life expectancy. Therefore, we can infer that a longer life does not translate into a happier life for both males and females. This further suggests that improvement in longevity are not necessarily leading to improvement in happiness. So till now we have talked about total life. Now let's delve deeper into the gender disparity to assess how additional years of life which female are getting through mortality advantage are spent. At national level, a gender gap of 1.8 year in total life expectancy means female live 1.8 years longer than males. However, out of this longevity advantage of 1.8 years, only 0.5 year is spent in only 0.5 year is spent in happiness and remaining 1.3 year is spent in unhappiness. Similarly, in Jammu Kashmir, female have a mortality advantage of 5.1 years, but out of these 5.1 years, only 2 years are spent in happiness and remaining 3.1 years are spent in unhappiness.
So, Mr.
In the case of Jharkhand, a
Sadanand,
gender gap.
sorry to interrupt. Please wind it up. Conclude. No.
Okay, ma'am. Okay, ma'am. So, just 1
Yes,
minute.
1 minute.
In the case of
In a
Jharkhand, a
minute.
gender gap of minus. Yeah, sure, ma'am.
Yes.
A gender gap of minus 1.1 shows that females are living 1.1 year lesser than males. So this graph shows the gender gap, decomposition of gender gap in happy life expectancy into happiness and mortality effect. We can see that the mortality effect is positive, which means mortality effect is contributing to have higher happy life expectancy for females. However, in negative, happiness effects shows that happiness level results in decreasing the happy life expectancy among females. So this graph shows the gender age-wise decomposition of gender gap in happy life expectancy across different age groups. The age group-wise decomposition shows a mixed pattern. In India and states such as Assam, West Bengal, we observe that as age increases, the contribution of both mortality and happiness effect tend to decrease. In states like Haryana, Kerala, and Karnataka, a positive happiness effect across all ages shows that female happiness advantage at all ages lead them to live happy life years than males.
Sadanand,
So,
please
in
come.
conclusion,
We
yes,
have
ma'am,
to
last.
close it. Yeah.
In conclusion, we can say that female generally have a longevity advantage at age 60 than males, which is contrasted by their happiness disadvantage. Thank you.
Just give a closing statement. That's all. Yeah. Okay, thank you. Sorry to interrupt, but the time is up, and it is very interesting because Sadanand, because most of your major highlights is about life satisfaction with the life longevity. Majorly, I see that it is life satisfaction. So that is also indicating important of in future research about actual perceived happiness connecting to the happiness and quality of life. We will take up the questions in the later. Okay. Please stop share. We will call the next. Thank you. So is Mumtaj or Papai Burman is available? So shall we take Miss Mumtaj is available?
Hello ma'am, this is Papai Burman.
Yes, Miss Mumtaj. Papai Burman is available? Okay, right. Please share your screen. So now you have time for 10 minutes. Papai Burman?
Yes, ma'am.
Are you ready for presentation?
Yes, ma'am.
Yeah, please share your screen.
Just let me know that slides are visible. Then start.
Yes. Make it slideshow if possible. Your time starts now. You have 10 minutes. Please stick to your time.
Okay.
You can start your presentation.
Good afternoon, everyone. My name is Papai Burman, and I am a data scientist at IIPHG, Gujarat. Today, I am going to talking about my present research on linking between food insecurity to elder quality of life and its impact on life expectancy, a study of older individuals in India. Let's begin by defining the quality of life. It is a multidimensional construct that encompasses physical health, mental health, functional capacity, social life, and living conditions. Where is food insecurity? It refers to a consistent lack of access to enough food. It can severely affect quality of life, particularly among the older individuals. Coming to the life expectancy, it is a average number of the years a person can expect to live. In this present study, I have taken 67.3 years as a maximum living possibilities for the older people. Those are aged 60 to 67 years, respective the gender. And longitudinal aging study in India, it is a secondary data. I have utilized only OA1 as a cross-sectional data. Coming to the elder quality of life and its domain. The box plot shows that the highest score was observed in environmental domain, and whereas the lowest score was observed in social domain. And looking at the overall score, the for the older individual was 0.64. This finding suggests that while individuals had good living environment, majority of them faced challenges regarding the quality of social life, meaning that social life remains a critical area for improvement. Coming to the linking between food insecurity and quality of life, the box plot clearly indicates a decreasing pattern of quality of life scores over food insecurity, dropped from 0.64 to around 0.53 in score. The regression results also show similar findings, like it clearly indicates a negative association between food insecurity and elder quality of life scores. Looking at the overall score, for 1 unit increase in the food insecurity, there was a corresponding decrease of 0.12 in overall elder quality of life scores. Coming to the life expectancy and food elderly quality of life score, the figure shows that there is a increasing patterns of the predicted linear life expectancy as the elder quality of score increasing from 0 to 0.9. There is a increment was found 3.8 years to around 4.17 years, which is approximately 3.79 months increment in the life expectancy if that older person had the better quality of life. Further, I have tried to examine its reproducibility, and I divided the whole sample into two groups. One is train group, other is test group. Then we try to examine its reproducibility, and the mean absolute error was very low, 0.012. That means the results are significant, and result also shows that our predicted life expectancy and the test group life expectancy are aligned to each other, which means the results, which means that the results clearly infers that there is a clear association between food in elderly quality of life and the life expectancy. Coming to the findings clearly indicates that overall individual experience a better. Those individuals experience better the elderly quality of life scores in environmental domains and functional domains, whereas majority of them face challenges in social domain. Higher food insecurity was significantly associated with lower elderly quality of life scores. A significant role also observed for elderly quality of life expectancy on the elderly quality of life or life expectancy. Thank you.
Okay, thank you, Papai Barman. You have finished before time. It is good. So this is also very important. The food security has multiple components of availability, accessibility, utilizability, and many more social and economic components. Connecting to quality of life is a very good domain, and maybe after the last year also several changes might have been taken interest to study. So this will be also future interest of many other research scholars also. Thank you for finishing on time. So we will take up the question. We will take up the questions at the end of the present technical session. Okay, thank you. So is Ms. Muntaj available for the presentation? Ms. Muntaj, Khadija, anybody is ready for the presentation from the technical session group?
Oh, sorry to interrupt, ma'am. Mamtaj, can you unmute and speak? Mamtaj. Mamtaj, can you please unmute and speak?
So meanwhile, anybody has questions, please you can put in the chat box. I hope the chat box is available for you to put your questions. Miss Muntaj, if not available, Khadija is available. So to save time, any other presenter, Seema Biswas?
Ma'am, can I share my slides?
Yeah, Seema, is this Seema Biswas?
Yes, ma'am.
Yeah, your voice is very low. Please increase your volume and you can start sharing. Can you increase your volume little bit and start? Yes. Yes, yes. You're audible and start sharing, and you are aware that you have 10 minutes time for your presentation. Please start. Your time starts.
Ma'am, my slides are visible?
Yeah, your slides are visible. Yes, it is in slideshow mode. Please go ahead.
Thank you, ma'am.
Go ahead, Muntaj.
Good. Ma'am, it's Miss Seema Biswas. Good evening, everyone. Myself, Seema Biswas. Today, I am going to present my work entitled Flavonoids as Potential Therapeutics for Parkinson's disease. So we all know that Parkinson's disease is one of the slowly progressive chronic neurological age-related disorder that affects a small area of the nerve cell located into the midbrain called substantia nigra. So these cells are normally produce a chemical messenger called dopamine. Many of the symptoms of Parkinson's disease are arise due to the loss of these neurons. Decrease in the dopamine level can cause the abnormal brain activity leading to the impaired movement and other symptoms of Parkinson's disease. So Parkinson's disease are broadly categorized into two forms. One is sporadic form and other one is the familial form. The interaction between the gene susceptibility and environmental factor are responsible for the sporadic form of Parkinson's disease, and mutation in particular genes like PINK1, Parkin, DJ1 are responsible for the familial form of the Parkinson's disease. Mutation in Parkin protein is most common cause of the autosomal recessive juvenile Parkinson's disease. PINK1 along with the Parkin protein participated into the mitophagy pathway, and in this pathway they remove the damaged mitochondria from the brain cell. So what are the potential etiological factors which can lead to the Parkinson's disease? As I already mentioned, the genetic factor like PINK1 Parkin mutation can cause the Parkinson's disease. Along with this, pesticide exposure, rural living.
Sorry to intervene. Dr. Veena, can you just increase your volume? Dr. Seema, it's very low. We are not able to listen you properly.
Okay, sir. Just
Furthermore, little bit, because though I am using the AV8, it is little low. Try to make it higher volume. Yes, speak so that we can see if the volume is improved. Speak.
Ma'am, am I audible? Hello, ma'am. Hello.
Still it is low only. But
I think, Seema, you can just remove your headphone and then you speak without that. I think that will be better.
Sir, can I connect through my mobile phone?
I think now it's little okay.
Hello.
Now it is better.
Little louder.
Maybe stay closer to the speakers. If you have speakers, stay closer to the speakers.
Okay, ma'am. Okay, ma'am.
Yeah. Yeah, please continue.
Okay. Thank you, ma'am. So, environmental factor like some pesticide exposure and mitochondrial dysfunction, epigenetic modification like DNA methylation, changes in histone and oxidative stress can give rise to the Parkinson disease. So, mutation in this genes Parkin pink1, and I also mentioned that the pink1 and Parkin is participated into the mitophagy pathway. So mutation in these two protein can hamper the mitophagy pathway, which can lead to the ROS generation, and decrease the dopamine level can also cause the reactive oxygen species generation and misfolded protein aggregation into the brain cell. So when the misfolded protein get aggregated into the brain cell, then it forms the Lewy body and cause the neurodegeneration. Several dopamine antagonists are present, which are available to treat Parkinson disease, but they have severe side effects. So in our work, we want to identify some beneficial flavonoids molecule that can be used in place of this chemically synthesis drug molecule to reduce the risk of the Parkinson disease, and want to check how the flavonoid molecule can reduce the effect of the Parkinson disease. From the literature, we know that the flavonoids molecule have the neuroprotectant ability, and they influence the neural cells, and also they decrease the reactive oxygen species. So our aim is to identify beneficial flavonoids molecule which can treat the Parkinson disease caused by the pink1 and Parkin mutation. For this work, we have retrieved the Parkin protein structure from the protein data bank, and we modeled the Parkin structure because there are some missing residue in it, and then check their quality. And we also select 60 flavonoids molecule from the literature, and also retrieve them from the PubChem data bank and optimize them, and check the flavonoids admit property, because admit property and Lipinski filter is a parameter which is used to identify a potential drug candidate. And then we further predict the active site of the Parkin protein, and then prepare the protein and ligand molecule, which are the flavonoids molecule, and finally dock them to the Parkin protein. Then we by using the autodock tool and find the binding free energy, and then we perform structure-based quantitative structured activity relationship to check how the admit properties, that is physicochemical properties of the ligands, are related to the binding free energy. So for this, we first divided out flavonoids molecule based on their backbone structure. So first group is the anthocyanin, and we have observed that the hydroxyl and methoxy group in the 4', 3', 5', and 7 and 6 position can affect the binding free energy. Cyanidine is the base binder in this group. The binding free energy is -8.79 kcal per mole. And addition of the methoxy group in the B chain can lower the binding free energy. However, if the methoxy group is present into the 6' position, in case of pitidine, it lowers the binding free energy more. So when we compare the flavone molecule, we have observed that the presence and absence of methoxy and hydroxy group in A ring and B ring can significantly change the binding free energy. Butene is the base binder in this group, and if the branching side chain is present, then it can lower the binding free energy, which is in case of hesperidine and naringine. When we compare the flavone molecule, we have seen that
6-hydroxyflavone is the base binder in this group, and followed by the ugonine, bicalene, 7,8-dihydroxyflavone. Presence or absence of the hydroxyl methoxy group in the beading can significantly increase the binding free energy. However, if the methoxy group is present and hydroxy group is present in the beading, then it can lower the binding free energy, which can be observed in this slide. When you compare the flavonol molecule, the acetylene is the base binder and N-acetyl is the base binder among all the group of flavonoids molecule. So here we can see that the branching side chains here also can reduce the binding free energy. In case of routine, we can observe that if the methoxy group is present in the 3' position, then it can also lower the binding free energy. However, this position is very important. When we compare the amlitine and rhamnocin, we have seen that the presence of hydroxyl group in this position lower the binding free energy. When we compare the isoflavonoid molecule, that's in the base binder in this group, and we have observed that presence of the methoxy group in 5' position can lower the binding free energy, and also branching side chains can lower the binding free energy. When I compare the chalcones, we have seen that the epicatechin and catechin is the similar have the similar structure, and due to the similar structure, their binding free energy is also similar. When you compare the epicatechin and epicallocatechin 3 gallate, we have seen that branching side chains can lower the binding free energy. Fluoritine is the base binder in this group. When we compare the flavonol molecule, we have seen that garbanzol is the base binder in this group, and more present of the hydroxyl group can lower the binding free energy. After that, we want to check how the binding free energy is related to the pharmacokinetics property of the ligands. So we have picked the most commonly used drug ligands properties like X log P3 value, topological polar surface area values, water solubility values, black band barrier values, and molecular weight. And we plotted them individually. And we built a linear regression model to check how the binding free energy is related to these drug likeness properties. And we also analyze their coefficient of determination, that is R² value. And we have seen that the molecular weight show a relationship with the binding free energy. We have already know that the R², if the R² value is greater than 0.5, then we can say they are related. So here the molecular weight.
Sorry, Seema, you need to wind it up. Please conclude.
Ma'am, I will take one moment.
Yes.
So if the R² value is greater than 0.5, then we have said that it are related. So here the molecular weight shows that the R² value is 0.674. So to check the avoid the biasness, we divided the flavonoids molecule into the three set. We keep the 40 flavonoids molecule in training set and 20 flavonoids molecule in test set, and we individually plotted them. We randomly picked the samples and individually plotted them, and also calculate their R² values. And we have between the three sets, we have seen that the R² value is almost same, and there is some negligible differences. Using this data, we also predict the molecule. We also predict the molecular weight of the flavonoids molecule, and also we plotted them against the binding free energy. And we have seen that.
Miss Seema, please conclude. Please conclude. Give a conclusive statement. Yes.
Ma'am, I will take 30 seconds. So we have seen that there is a relationship between the molecular weight and the predicted R² value. Predicted R² value. So at a conclusion, we can say that if we know the binding free energy, we can predict by using this model, we can predict their molecular weight, or if we can know the molecular weight, we can predict their binding free energy using this model. And after this study, we can say that azolitine will bind more potently to the Parkin protein, and it can be used as a potential drug after some wet lab experiments. And in future, we want to design some small products that can target the damaged pink-1 protein to enhance the damage sensing ability. So lastly, I want to thank Professor Anshuman Bakshi for his guidance, deeply funded bioinformatics infrastructure facility, and the Longevity Asia for giving me the opportunity to present here. And lastly, thank you everyone for your time.
Thank you. Thank you, Seema. So we have seen your ambition of highlighting the potential therapeutic strategies of flavonoids. In consideration to the time, we have to stop you. Thank you. So we encourage the audience and we encourage everyone, whoever is interested, to put your questions in the chat box, and you can take up see the chat box to answer them by the end of the technical questions. Thank you. Okay. Thank you. Seema, you can you have stopped the sharing. Yes. Thank you. So next, is Mumtaj available? Next presenter. Yes. Is Mumtaj available? Please confirm. Yes, and yeah. Share your screen. And you have 10 minutes for your presentation. So please stick to your time so that we can, all the presenters will get their own time slots. Muntash, are you available? We can't see you yet.
I'm just sharing my screen.
So meanwhile, we encourage all the audience and everyone, whoever is interested, put your questions for specific presenters, whatever the questions you have in the chat box, so that they will be able to take up your questions by the end of the technical session, or they can even answer in the chat box. Muntash, do you take time? Shall we take up the next presenter?
Ma'am, I'm trying to share my screen.
So, is Khadija or, yeah, you can try if time taking. Is Firdosh Shah is available for the presentation?
Yes, ma'am.
Yeah. So, Muntaj, do you want time? Will you be ready for the next presentation? Shall we take Firdosh Shah? Are you ready for this? Be ready with your technical requirements. And Firdosh Shah, are you ready for sharing the screen?
Yes, ma'am. Can I share my screen? Am I audible?
Please. Yes, you are audible. Please share your screen.
Just give me a moment.
So sorry, Muntaj, be ready with your technical requirement, and sure, we will take up soon after Firdosh.
Sure, okay.
Okay. So Firdosh, please share your screen.
Is my screen available?
Not it. Yes, it is coming up. Yeah, please. Can you make it slideshow? Yes, you have 10 minutes time. So please go ahead. Okay. Yeah. So stick to your time. You have 10 minutes time. Go ahead. Over to you.
Okay. My name is Firdosh Shah. I'm a PhD student from CG Bhakta Institute of Biotechnology. And the title of my presentation is Regulatory T cells Aging Contributes Generalized Vitiligo Pathogenesis. So like any other organ system, immune system is also susceptible to age-related changes. There are studies which says that the deterioration can be caused in immune cells through aging. And there are ample emerging studies which are saying that due to immunosenescence or due to aging, there is a shift between
Firdosh, sorry to interrupt you. Your voice is breaking.
Yes, ma'am.
Your voice is breaking. In case if you have any difficulty, maybe you can switch off your video so that your internet may get catched up. In case, and also your slides also are not moving. Please. Yes. Okay. Continue.
Okay. So basically, the title of my presentation is Regulatory T cells aging contributes generalized vitiligo pathogenesis. So like any other organ system, immune system is also susceptible to age-related changes. There are studies which says that deterioration of immune competence can lead to shift between balance of protective and pathogenic immune responses. There are emerging studies which say that
your slides are not moving. We are still at the...
it is on the first. It is on the first slide. I'm just giving an introduction. Yeah.
Okay.
So there are emerging studies which says that when there is a progressive aging of immune cells, there is significant effect on the frequencies of cells, their substrate distribution, as well as functional incompetence of Tregs. Therefore, in this study, we have tried to focus on how Treg cells basically, or the aging in Treg cells, contributes towards immune pathogenesis and vitiligo. So coming towards what is generalized vitiligo. So generalized vitiligo is an autoimmune skin depigmenting disorder which results into loss of functional melanocytes. And there are different factors which have been responsible. Cause has been clear-cut considered that this is causing vitiligo. So our group majorly focus on the autoimmune aspects of the study, where we have targeted regulatory T cells, which we have designated as Tregs. These are a subset of CD4 T cells, and they play a very important role in maintaining immune homeostasis. So in our previous studies, we have said that in generalized vitiligo patients, the Treg cells numbers was found to be compromised, both quantitatively as well as qualitatively. And there are some other studies which also says that the aging can decrease the Treg cells number, and it can also cause an impairment in their function. So in order to assess that, we have focused on the telomere length. The telomere is composed of repetitive DNA sequence, which is having a sheltering complex. So as we know that at every DNA replication cycle, there is a gradual decrease in the length of telomere. So till now, nobody has done the study which has investigated the telomere shortenings of Tregs in GV patients. So coming towards what was our objective, so main aim of our study was to find telomere length regulated T cells within the South Gujarat population of India, and we correlated this telomere length with the in vitro Treg suppressive capacity. So if you can see here, this is a methodology where we have collected 96 patients blood sample and 90 healthy controls blood sample. And from there, through magnetic separation, we isolated 3 types of cells: CD4, CD8 T cells, and T regulatory cells. Then we expanded them in vitro through co-culture system, and we did a BRD cell proliferation ELISA kit in order to determine whether these T regulatory cells were able to suppress the hyperactivation of CD4 and CD8 T cells, which were killing the melanocytes. And on the other hand, we were also isolated DNA from Treg cells, and we did a qPCR to find the telomere length through qPCR, and we found that relative telomere length, and we correlated the Treg suppressive capacity with the telomere length. So this is the overall finding. As you can see here, that is a demographic characteristics of our patients. We bifurcated patients on the basis of gender. We also did the age of onset and disease on the basis of disease activity. We divided patients onto 2 categories, vitiligo, and we did a severity index, that is VASI score, where we divided patients on the basis of 3 groups: mild, moderate, and severe, which is just in general information. Coming to the main findings. So what we found is that there was a reduction in relative telomere length in GV patients compared to controls, as well as the 0 to 20 years of age group. They have a more relative telomere length to be more reduced compared to the elderly patients. And same happened for the age of onset group. We also did one more analysis on the basis of gender, disease activity, severity. There we didn't find any significant difference. Coming to a correlation analysis data, we found a positive correlation between the relative telomere length and the suppressive capacity of CD4 and CD8 T cells. So overall, what we found of Tregs and positive relative telomere length. Also, the relative telomere length also correlated with the IL-10 and TGF beta levels. Now, this IL-10 and TGF beta levels are the cytokines which have the immune, main suppressive functions towards Treg cells, immunosuppressive capacity. So there also we found a significant difference. So coming to us, what were the key findings of the study? So the study found that there was a significant difference between a relative telomere lengths in Tregs of GB patients compared to the healthy controls. Also, the telomere length was significantly reduced in elderly GB patients compared to the younger patients, that is 0 to 20 years. Also, the early onset of GB patients showed more reduced telomere length compared to late onset group. So overall, what we can conclude here is that the Treg aging may be contributing factor in telomere shortening, and that can alter the Treg function in GB pathogenesis. Also, we conclude that the telomere shortening in Tregs may also result in Treg aging, and that can hamper the suppressive capacity of the Treg cells in GB patients. So this is the first evidence. Our paper is the first article which has shown that there is a decrease in telomere length in GB patients' Treg suppressive capacity, and that could be a possible reason for decreased Treg numbers and function in GB patients, which we have found in our previous studies as well. So this is overall the presentation. So thank you so much.
Thank you so much, Firdaus, by finishing on time. So though it looks like you have some, you can just on your video for your conclusion. Okay. And so your looks like you have got some connectivity issue. However, you have managed on time. So okay. the questions maybe interested candidates may pose interested ones put in the chat box. You can just go through. If any questions are focused for your presentation, you can answer them at the end of the technical session. Okay, thank you.
Okay.
So talking about, yes. So talking about the contribution of regulatory T cells on the vitiligo is a very interesting area. So we will discuss if any questions are there at the end of the technical session. Thank you. Is Muntaj ready now? Miss Muntaj, are you ready for the presentation? Meanwhile, please post your questions in the chat box related to any presenter in specific. You can indicate which presentation you wanted to have the questions, and they can be taken up at the end of the technical session. Miss Montaj, are you ready?
Yes, ma'am, I'm ready.
Please share your screen. No, you are sharing the agenda of the program.
Yes, ma'am, I'm just trying to. I don't know what it is.
Do you have difficulty in sharing the screen still?
Yes, ma'am. I'm not getting it. Is actually in my Gmail and
actually, so organizing team, did they send the presentation? Do you like to share? Did they share the presentation to you already? Dr. Divya or whoever is in the team, did they share your share the presentation to you already? Do you have? In case, do you like to share?
Yes, please. If from your friend, please share.
Okay, ma'am, you please continue with the next presentation. I will keep it ready for ma'am.
Okay, okay, Mumtaz, please, you may just keep your be next presenter. Is Dr. Maheshwari available? Dr. Maheshwari, available? Khadija?
Yes, ma'am.
Khadija is available. Okay, can you share your screen?
Okay, ma'am.
Yeah. Khadija, please share your screen. Yeah, Maheshwari can be next. Khadija has been available and she's sharing the screen. Dr. Maheshwari, you can be next after Muntaj.
Ma'am, the
Khadija,
screen is visible.
Not yet. Not yet. No. Keep your presentation ready if you would like to have the next presentation. Are you ready to present? Do you take time? So shall we take up Dr. Maheshwari? Are you available? Please respond. You can respond if you are available. We can go ahead with your presentation. Yes, Dr. Maheshwari. You can on your microphone. Just answer if you are ready. Yes, I can see you have raised your hand. Dr. Maheshwari.
Ma'am, I have, sorry to interrupt. I have Mamta's presentation ready. I can share.
Okay then, and because Dr. Maheshwari also raised her hand but not answering, so okay, Khadija, keep your presentation ready. So Muntaj, are you available? Your presentation slides are ready. Are you ready for presentation?
Yes, sure, ma'am.
Yes, Muntaj. Yeah, Dr. Divya, please share her presentation. You can present from your side so that she can present her. She can start talking. Muntaj, you have 10 minutes time from now. So you can see the slides, right?
Can you see the slides?
Yes, it is visible.
Yeah,
Yes, please go ahead. Go ahead, start presenting. You have 10 minutes. Please stick to your time. Go ahead. Over to you. Go ahead.
Okay, good afternoon, everybody. First of all, I'd like to thank the organizer and all the supporting cells behind the successful organization of this symposium. It is my pleasure to introduce myself at this and my paper at this platform. I am a PhD scholar in CSDM University, Kanpur, and recently I'm going to present my paper which was published on BBRC journal. The topic of my research paper is therapeutic effect of oxyxylo in diabetic wound injury. As we all know, diabetes-related food ulcer are one of the most common complications of diabetes, which isn't managed with dietary changes, exercise program, or insulin therapy, and also a substantial cause of morbidity and mortality. Annually, about 18.6 million people worldwide suffer from diabetic foot ulcer. Comprehensive understanding of diabetic foot ulcer pathophysiology is therefore crucial to creating effective management strategies. One of the most important treatment being investigated for diabetic wound healing is nowadays nanofiber-based approaches. The possibility of therapeutic intervention with nanovesicles like exosomes and exosome-like extracellular vesicles has recently come to light. Actually, exosomes are concept morphology, which when observed under electron microscopy, and
it is of great importance because it actually carries all the proteins, RNAs, lipids, and metabolites that can be present at the particular anything that is present in the liquid form, plant or anything else. It is exosome can be isolated, and it carries all the properties of that particular thing. What we have done is actually we have formulated a therapy using Azadirachta indica, Aloe barbadensis, and Gingiva officinale, which was processed for ultracentrifugation and then filtration. After filtering, the extracts were mixed in an appropriate amount to see whether their effectiveness is enhanced or not. And while we tested this, we found that mixing these things in appropriate amount, it gives very beneficial results in while we applied it on diabetic rat model. The working mechanism of oxy-exo-elo is actually oxygen. It is usually oxygen species which oxygen species majorly contributes in diabetes and its wound healing. Oxidative stress disrupts the balance, leading to the impaired cellular function, and excessive reactive oxygen species accumulation delays the inflammatory responses and hinder the formation of new blood vessels, collagen synthesis, and ethylation, all of which are crucial for proper wound healing in diabetic patients. We have done the in vivo studies for which we have constructed the diabetic model by using the streptozotocin induced diabetic rat, and for that we use the Oyster rat model. What we have done is actually we injected the rat intraperitoneally on a day 1 and 3rd, and freshly prepared the streptozotocin was freshly prepared in a cold sodium citrate buffer. And first of all, the four of rat was saved off, and then using the biopsy punch, wound was made on the both sides at their thigh region. The advantage of oxy-exo-elo are traditionally we believe to have medicinal values of these plants, and their bioactive nanovesicles could contain the medicinal properties of these plants. Due to their less side effects, natural products are becoming increasingly popular in the cure, prevention, and management of diseases around the world. We have performed the RT-PCR assays and TNF alpha and IL-6. These are the biochemical markers, and the cytokine level was estimated by the ELISA test. Further, gelatin zymography assay was also performed by taking a rat on the skin samples, which were ground and analyzed using sodium dodecyl sulfate, polyacrylamide gel electrophoresis, and which was prepared with 2% gelatin. After washing yes, and this
we have lost you in between. Please check your technicality and.
So it might be due to solver issue, ma'am. Yes. This diagram, this is the image which were taken during the treatment course, and this second diagram shows the heat map representation of healing rates in different groups over the treatment course, and delayed wound healing are common complications for. Lastly, I would like to conclude myself. Delayed wound healing are common complications for diabetic patients, and in light of chronic hypoxia delays in wound healing, it is hypothesized that providing a better oxygen environment at the wound site will promote the diabetic wound healing. Oxyexolo is an innovative and effective therapy prepared from the exosome, like vesicles of different plants like aloe vera gel, ginger juice, and neem fruits sap. And the combination of these herbal oxygen delivering herbals are oxygen delivering and medicinally valued plants was standardized to determine if the combination had the desired effect. And we used oxyxyl as a particular ratio on a diabetic wound, and the herbal therapy speeded up and wound healing by reducing the swelling and the severity of the wound. And finally, our data suggests that the oxyxolo could work by decreasing inflammation, cytokine management, ECM remodeling, accelerating oxygenation, and accelerating re-epithelialization in STZ-induced diabetic wound healing. There are some of the future direction I have mentioned there, that oxyxolo have more detailed research is required to understand its detailed mechanism, and clinically it should be tested for its further whether there's any side effect or not, and is it safe to use for human beings as well. And further, it can also be incorporated in gel, and we can also develop it as a hydrogel. Yes, that's all from my side. Thank you so much.
Okay, thank you, Mumtaz. Completing on time. So your talk is interesting, though sometimes we have a little bit break in your voice. So your therapeutic effect of oxyxolo in diabetic wound injury also is a very contributor for the promoting the quality of disease management and quality of life among the patients. So that is also one of the essential contributor. And if anybody has any interesting questions, they will put in the chat box. Thank you for your presentation. Okay.
Thank you.
So we will take up the next presenter. Ms. Khadija, are you available?
Ma'am.
So are you ready for your sharing the screen and presentation?
Yes.
Please go ahead without any further loss of time. Please present your screen.
Is it visible, ma'am?
Yes, visible. So you have 10 minutes time. Please start your presentation. Go ahead. Over to you. Start your presentation.
Okay, myself Khadija. I'm a final year undergraduate student of Adi Shankara Institute of Engineering and Technology. Thank you for inviting me to Symposium. It was an excellent event and I truly appreciate the opportunity to be part of it. Smart Fall Detection, Jacket for Elderly is a group project that I have done in college, and these are my 3 members and done under the guidance of Dr. Teresa Joseph and Dr. Ramya George. Imagine a world where the fear of falling is no longer a daily concern for our elderly loved ones. Falls are one of the leading causes of injury and hospitalization among scenarios, impacting their independence and quality of life. But what if we could provide them with a reliable safety network, one that not only detect falls but also protect them from injury? Today, we will explore a breakthrough solution, the Smart Fall Detection Jacket, combining advanced sensor and protective technology. This jacket is designed to detect falls in real time, send alerts, and provide immediate protection, offering peace of mind for both the elderly and their caregivers. The global aging population faces a critical challenge, that is fall. The consequence of fall extend beyond physical injuries, leading to psychological trauma and fear of falling that can limit self-confidence and motivation for independent living. This often results in reduced activity, further loss of strength, flexibility, and mobility, thereby increasing the risk of future falls. While various fall detection systems currently exist, they often exhibit significant limitation in terms of accuracy, affordability, like wearability, and real-time response, etc. For instance, false alarm triggered by everyday activities can undermine user confidence and trust in these systems. So the main thing motivated us to do this project is a growing threat of falls, the accelerating aging population intensify the concern over falls, and which is a major injury that the elder face. And the other thing is the limitation of existing solution that we have already discussed about the expenses, hindering widespread adoption, etc. And so here I'm introducing advanced sensor technology and embedded system like ESP8266 and MPU6050 sensor. These compact and affordable components hold the potential to create a reliable and cost-effective fall detection system for a vision for a better future. So these are the main objectives that have gone through. The first thing is the innovation of fall detection system using the microcontroller and MPU6050 motion sensor. And here we are developing an airbag system that deploys upon when a fall is detected. And the third thing is when the fall is detected, the corresponding location of where the fall has happened is corresponding location is obtained to the caregiver. And the fourth one is to develop an alert system that will also a notification message will send to the caregiver's mobile number. And the last one is to develop a deflate airbag system to ensure comfort and prevent prolonged pressure. That is, when the fall is detected, the prolonged pressure on the user body will cause severe impact. So here we are developing a deflate airbag system also. And this is a problem statement to develop a system that accurately detects fall using advanced algorithms and deploys a protective airbag to minimize injury risk, which also aim to ensure prompt assistance by triggering automatic notification to designated caregivers or emergency services. So this is the basic block diagram that we done. First, when the human movement signal is detected by the sensor, the microcontroller, which is the heart of the entire system, that is ESP8266, and when the sensor is detect when change in the human movement signal, like when they are supposed to fall, the sensor sends an signal to the airbag inflator module, and the inflator will inflate the airbag. Also, we can the caregivers get the GPS module through the GPS module, the access of the location, and also the notification message through push safer application. And we are also including a buzzer that the nearby to inform the nearby ones. This is also a detailed block diagram of our proposed model. And this is the expected model of the jacket that we are planning to design. This is the jacket when the before the jacket when the fall happens, and after the jacket when the fall is done. And these are the key features that about the jacket design: a measurement of the jacket inflation mechanism upon detecting fall, the node MCU MPU6050 sensor using that fall is detected, and there's an inflating pump or air module for inflating the airbag. Actually the coverage areas of the jacket is the neck, that is cervical spine, and torso, that is chest back sides, and the main important, that's the spinal cord is also protected by this jacket. And the next, the main core functionalities of proposed model includes: first is the fall detection. The MPU6050 is the main thing, the main sensor that is detecting fall upon fall is detected. So here, the algorithm could detect signals around 300 milliseconds before the fall is going to happen. The location also, when the fall is detected, the location is sent to the corresponding caregiver's phone through Neo 6M GPS module. And the next thing is the alert mechanism. You are including a buzzer that emits a loud sound to alert the nearby individuals for quick assistance and sends an automated notification message to designated contact. And next is the protective jacket. That's the main thing that we are designing. That is the inflator pump. Using the inflator pump, the jacket is inflated when the fall is detected. The jacket contains a cushion and which protect the individual from injury upon a fall. The entire process of signal detection, processing, and the relay activation typically occurs within 50 to 100 milliseconds. So the average inflation time is 0.12 seconds approximately. Combining all these, the entire thing is completed within 1 second. And this is the circuit diagram of the proposed model. So here we are using Neo6M GPS module, MPU605 sensor, Node MCU, airbag module, finally the air jacket, etc. And this is a flow chart. Here how the fall is detected upon the changes in the human signal, human being movement is when we set a threshold magnitude, and when the accelerometer magnitude is greater than this threshold, corresponding the sensor will detect that is the fall is happened, and corresponding signal is sent to airbag, and the airbag is inflated by through the inflator or airbag module, and finally at that time the GPS location and SMS is sent to the corresponding caregiver's mobile phone, and along with that the buzzer will also alert the nearby ones. So this the methodology has for the methodology it has been done in two, that is software development and hardware development. So in software development, C++ programming language is used for used and is done in Arduino IDE platform. So the notification is given through the safer application to the designated contact at the time of fall. And this is a hardware development. Hardware development step includes the assembling of the components such as MPU6050 sensor, Node MCU SP8266 microcontroller, Neo6M GPS module, buzzer, airbag for ensuring the proper connection. And here we already told about MPU6050 sensors for detecting the fall, and Neo6M for GPS access. And once a fall is detected, the microcontroller initiates a signal to relay, subsequently triggering the activation of the airbag module. Also, the buzzer is activated to provide an audible alert. So this is the interfacing of the Node MCU ESP8266 with MPU6050 sensor, relay module, buzzer, Neo6M GPS module. And finally, the integrating the software and hardware for getting the all these things in practical. So finally, by combining all these, we get the result from that objectives from 5 objectives to develop an innovative fall detection system using microcontroller and MPU6050 motion sensor. Here we are setting a threshold, and when the algorithms were implemented to process the data from the sensor and identified fall patterns, a threshold was established to differentiate normal activities from fall. The effectiveness of the fall detection is evaluated by testing under various conditions such as walking, sitting, falling to ensure the reliability. The values obtained from the Arduino IDE is plotted to form a graph that signal patterns. The highest peak represent when at the time of fall is detected. And the baseline measurements used are under normal conditions, fall even and pause fall. Under normal condition, the X, Y, and Z values fluctuates around small values. And when a fall has happened, there is a sudden and significant change in acceleration in one or more axes. This results in a sharp increase in the magnitude. And when after the fall, the person is immobile, the accelerometer readings might stabilize again, but at different values depending on the final position. And the objective 2, the airbag system is designed to deploy upon detecting of fall through MPU6050 sensor, microcontroller, and airbag mechanism. And the signal is sent to the relay module, and by power supplying the relay module, the airbag deployment mechanism happen. And effectiveness of the developed fall detection algorithm is is evaluated by experimenting on 2 subjects through backward fall and forward fall. And these are the measurements that I've got during the experimentation results, and by these experimentations we get an conclusion that the triggering time of average, that is 0.6 seconds, is obtained for the proposed algorithm to detect fall is happen, and finally the inflation of the airbag system is happen.
Khadija, please conclude.
Oh yes,
please
ma'am.
please conclude.
This is a final proposed jacket before inflation and after inflation.
Yes.
So finally, tracking
You have to
system
conclude
and,
you have to conclude now. Your time is
okay,
up.
ma'am, 1 minute. I will conclude. So this is the GPS location accessing, and finally the deflation of airbag system. So the conclusion is the project can make a significant impact on fault prevention, leading to safer and more independent future for many. And also a lot of future scopes on this project on advanced detection and enhanced interventions, personalized experience and research and development. So that's all about my presentation. Thank you.
Thank you. Sorry, we had to hasten up because the time constraints are there. Although it is very interesting also. Perhaps personally, on my personal behalf of also, it is very interesting for my research area also. I too have plenty of questions, but I cannot put in them now in consideration to the time. And you have already few questions in the chat box. You can keep reading them. And we will take up other questions at the end of the technical session. Thank you, Khadija. So,
thank you, ma'am.
So we will take up the next presenter, Dr. Maheshwari.
Yes,
are you ready
ma'am.
for your presentation? Yeah.
Yes,
I
ma'am.
think this is the final presentation of the final technical session. Please share your screen.
Is my screen visible, ma'am?
Not yet. Not yet.
No, ma'am.
Yeah. Yes, your screen is visible. If possible, make it a slideshow and start presenting. You have 10 minutes time. Please stick to your time. So you can start presentation. Yes, over to you. You can start presentation. Can you make it a slideshow if possible? Otherwise, go ahead.
Yes. And I'm Dr. Maheshwari, Assistant Professor Social Work, Banaras University, Tiruchirappalli, Tamil Nadu. And I'll be presenting a paper on association of socio-economic status and activity levels among the rural older widows. And regarding the introduction part, changes in the traditional family system and the shifting social values are not only cause serious problems among the aged population, but also among the vulnerable groups such as women and widows. And it's also known for the past 2 days, we're having the symposium on status of older persons in India, as well as the feminization of aging. I'll go to the next part. Widowhood generally considered as a women's issue, particularly older women's issue. And also due to the cultural and societal norms, elderly women are not even permitted, or they themselves voluntarily withdraw and isolate from the society, and they don't take part in social and physical activities. As a result, they experience reduced mental functioning and restricted social participation. So, and when you're seeing various studies, where majority of the studies focus on the physical dimension of the older persons, but and they and the instruments also focus on the daily living activities of the older persons. And in general, as a researcher, I would like to focus on the psychosocial aspect along with the physical aspect activities together. So, as per my study, activity is a focused behavior and ability of a person can perform, and it is also known that body and mind do not work separately, and activities must be considered as a unified concept. The activity of a human being comprises the other aspects of physical, social, psychological constructs.
Dr. Maheshwari, Dr.
Yes,
Maheshwari, sorry to interrupt. Are you moving the slides? Your slides are not moving.
It's moving here.
No, not moving. Can you just check? Your slide, the first introductory slides remains there.
Okay.
How about others? Yes, slides are not moving, right?
Yes. It's moving, ma'am?
Not yet.
No, I think you are in the, you're sharing the wrong screen, Dr. Maheshwari.
Okay.
Maybe just for a while, stop sharing and redo it again. Sometimes it rectifies.
It's not visible, ma'am. It's not moving. Is it moving?
Yes, but can you? Is this a slide you are talking now? Is this a slide you are talking now?
No,
yeah, go ahead. Please go to the beginning. Yes. Move
Yes,
to
this
the
is.
Now it is moving forward. Yes. Now it's, yeah. Please,
Yes,
please resume your presentation. Resume your presentation.
Yes, ma'am. And wherever there is some concern for the widow or the elderly, the focus only is on the physical dimension and stressed upon. And majority of the instruments which measures the physical health of individual don't concentrate much on the psychosocial aspect together. So in my study, higher focus that activity as a focused behavior and ability a person can perform. Mind and body do not work separately, and activity must be seen as a unified concept. Physical, social, and psychological concepts must be seen together. Regarding the methodology, and the aim and objective is to find out the association between the socio-demographic characteristics of the respondents along with the activity levels among the rural or elderly widows. Descriptive design has been used, purposes sampling method, and in this for the study, a standardized tool developed by Maheshwari and Ilango in 2010 that on activity rating scale for older persons, and this scale consists of 30 items with 3 dimensions: physical, psychological, and social activities. And regarding the major findings of the study, it is noted that regarding the age factor, there is a significant difference among the age of the respondents and various dimensions of activities like physical, psychological, and social activity. And majority of the respondents fall among the young old category. That's really 70%. And from the study, it was clear that and most of the respondents have become widowed by 60, at the age of 60 to 64 years of age. And regarding the majority regarding the occupation of the respondents, majority were doing agriculture, and especially they were doing working as agricultural coolies. And it is also interesting to know that nearly 73% of the response family members were dependent on the income of the respondents, and they were the support, economical support for the family members. And more than half of the respondents have said that they have lived with their spouse for more than 3 decades, and the status of the life partner decides the status of the women as well as they are widowed, and their status in the family also. And according to the study, social media plays a vital role. And majority of the respondents have used their mobile phones, especially to make a call for their children. And they also response were also much associated with their daughters than compared to their sons. And majority of the adult elderly widows were residing with their sons. Nearly 66% were residing with their sons. And regarding that, religion does not play a significant role in the activity levels of the older widows, and majority of the respondents have followed Hinduism. And as per the study, widows have told that they don't go to temples frequently, and they worship God at their home itself. And during occasions or during festivals, they go out with their families for their to worship God, that they have informed. And it is also interesting to note that more than half of the income, due to income, they have a better stand in their families, and majority of the respondents were not dependent; they were independent. They can decide own things. And regarding that. And majority they were as I already told that they were doing they were working as agricultural coolies, and few percentage of the respondents had their own properties, and they were not paid when they're working in their lands. And majority of their respondents nuclear families. Here I mention is they live along with the sons, and nearly 30% of the widows are living alone, and they have no access to the property. And all the respondents are moderately active with their physical dimension, psychological dimension, and social dimensions. Another important thing we have to see here is ventilation. Ventilation with the peer groups and neighbors serves as a major psychological support for the older widows, and they go for occasionally social gatherings during weddings or functions or festivals, and their family members, they get together. And they also, when they see their peer groups or their friends at their age, they used to have discussion on the past events, and everybody, and it is from the study seen that everybody do their daily living activities by themselves. And another interesting thing is the frequency of meals. And most thing we don't concentrate in our research, the frequency of the meals, the quantity of meals, and the serving persons also have a deciding role in the physical health of the older persons. And the older elderly widows insisted that when they expect their sons or the person who is available in the house to serve them, and if they are having some a special dish or non-veg, they expect their sons or daughter-in-law to serve them. And it also noted that if they have some anger or some misunderstanding with the in-laws or something like that, they show their anger in the meals. It was reported by the respondents, and this also has an effect on the physical health of the respondents. And if they are based on the study, if they are active and physically active because of their occupation, they are physically active, and this physical activity makes them to be psychologically strong, as well as they have a time to share their feelings with their friends or peer groups, so that they have a time for ventilate their burdens, and this gives them an especially their occupation gives them an occasion to share their feelings. And there is a cognitive decline was less likely to affect the women who were physically active at baseline. And from this study, I would like to conclude suggest that the decline in the family ethical values have made the members to be individualists, and weakening of the family relationship and occupational primacy have allowed and made the youngsters to spend little time with their parents or the elderly people. And I insist here, sensitization among the younger generation as well as the family members is a need that and we must give enough time for the older persons to live on their own, because I have seen this in my streets. All the grannies join together, they have their own schedules, they go for walking correct at the time 5 o'clock, they go for walking, and they make them physically active, and they do the household chores also. And unless the in-laws others interfere with their style of living, they are happy on their own. So it is important that we must give space for the older persons, and we must understand older persons. As aging is common, everybody will face it. Even their understanding on age is entirely different. We have to understand that concept, give space for them. And I would like to conclude that if a person is physically active, automatically the psychological health will be improved, and the social gatherings will be improved, social participation, socialization will be improved. So that when seeing a person's activity, it must be seen as a unified concept. Physical, psychological, social activity must come together, seen together to understand the quality of life of older persons. Thank you for the opportunity. Especially thank the organizers for accepting my presentation at the last moment. Thank you for the opportunity.
Okay. Thank you, Dr. Maheshwari. It was very socially eye-opening presentation, I would say. So thank you. So you can stop sharing the screen, and so now I hope we have come to the end of the technical session. So we had 8 presentations, and I thank all the presenters for the wonderful presentations. And before I ask for any questions, and there are 3 questions to wind up. Like for Khadija, there is a question: do you really think that in such a global climate perspective, where the temperature is gradually increasing and heat waves are also there, wearing a jacket, is it all feasible to someone elderly? Is the question. Khadija, do you like to answer?
Yes, ma'am, I would like to answer.
Yes. Just don't take too long, just few seconds.
Okay.
Yes.
Being a pneumatic jacket, it is an absolute solution for hot and humid climate. The design need an additional cooling chamber, one that can be worn around the waist, and circulation system too. The cool air can be circulated at the rate of comfortable for the user. The same circulation system can be used in the event of fall. Only difference when the fall is detected, the rate of inflation should be drastic.
Okay. So if any more discussions, maybe if you are comfortable, you can put your email ID so that they will contact you directly. And then the next question is, Dr. Maheshwari, how are you able to remove the bias of the selected population for the study? Do you like to answer, Dr. Maheshwari?
Yes, ma'am.
Yes.
And that's what when I was mentioning the methodology, I have used purposive sampling method and selecting the respondents for the study. And as the list was not available regarding widows, we were getting the information from one household to the household. Through that, we selected the respondents. So bias was not there, I think so. Thank you.
Okay. In case you are also, if comfortable, you can leave your email ID. They may approach you for further questions, if any. So
Yes.
it was wonderful to hear all the 8 presenters in this technical session. And it is very wonderful to hear that, because it is a combination of varied backgrounds of public health, I can see. And also there are life sciences related, and also social work, and also the engineering studies, technological based. And it is like Paramita has discussed about the quality of life. 2-3 members discuss based on the LASI study, and also gender differences Sadanand has discussed, and therapeutic and innovative strategies to deal with not only the diabetic injury. And also Khadija just a while ago spoke about the innovative strategies, that is technical applications in the fall prevention. And also the Seema Biswas has discussed about the flavonoids for the Parkinson's, which is also a future challenge. Firdosh has talked about the regulatory T cells in the vitiligo progression. Vitiligo nowadays, if you see the tropical changes or whatever the various predisposers, the number of cases are increasing, which is also seen as a public health challenge too. And also Dr. Maheshwari has highlighted about the social perspective of especially the single women or the widows in the later part of the life. So all these interdisciplinary and varied backgrounds gives us very eye-opening introspection of the challenges of not only aged population and also the future aging. So having said this, I would specifically like to thank the organizers, Professor Dhananjay and also Professor Shashanka, Professor Shekhar, and their contribution, entire organizing team, for your patience and also for your diligent and meticulous planning of the sessions. And until the end of the day, I can see you are starting the 2 days from 9 o'clock, and until the end of the day, you are relentlessly pursuing and monitoring the system. And thank you. And also it is pleasure for me being part of this. I would look forward for more from you like this. And it is the need of the hour for the society, for all of us to spread the message, and for capacity building sessions like this. Thank you. Over to Professor Dhananjay.
Yeah, thank you, ma'am, for conducting such a wonderful session, because I know this is the last session and it's very hectic, because all 8 presenters presented their papers in these technical sessions, and since it's a Saturday holidays and also the late hours, but you have very effectively managed all those papers. So thank you so much, ma'am, for agreeing to chair these sessions as well as managing very well. So thank you so much, and we hope that in future also we'll have in such kind of sessions. We'll invite you and hope that you will definitely come for such sessions. So thank you.
Yes, I have.
Yeah.
I have started the process already by inviting you. We will certainly work.
You already invited me, and I'm happy to join that. Next month I'll be there. Thank you
We
so
will
much.
certainly work together. Yes, thank
So
you.
we look forward for some more opportunities to work together as well.
Yes.
So
Sure.
now we have already reached to the end of the sessions, because end of the symposium. This is the last sessions of the symposium, because last 2 days we work hard, or we can say that continuously since morning 9 o'clock to 6:30 we work, or we had a presentations, and we have a lot of papers, lot of discussions and all those things. So I will not take much of your time, because your people are already tired. So I'll just quickly, because this is a wrap-up session, so in just 10 to 15 minutes, we'll wrap up this final session. So I'll now request Dr. Shankar to say a few words, and I'll just take 5 minutes, then finally we'll just wrap up. Over to you, Dr. Shashank.
Thank you. First of all, let me thank everyone who participated in this and make this as a successful event, starting with the students and sharing their research interest, their research work, to all the way to the esteemed professors and everyone. You know, when we started this journey, Dr. Dhananjay, you and I, when we started this journey, we started way back. One of the key things what I learned out of this conference is, longevity, aging, and quality of life. As much as people want to put this into one bin, it can't fit into one bin. There is an engineering aspect, just like the jacket, smart jackets, and then there is social science aspect, and then there is genomics aspect. So the conference, in the end, I look back and I see it captured the essence. I'm glad that we started where we started, but it is very wonderful to look into all these aspects, and I'm very thankful to everyone who joined and shared their research interest. And more importantly, I want to thank every chairperson who kindly agreed to chair the sessions, and all the presenters, and then our internal teams, our volunteers, collaborators at Renix, and also student volunteers and other volunteers from IIPS as well. They have relentlessly worked, and throughout the conference, I know personally it is, I am in Houston, so personally it is very challenging for me to stay all night, but yesterday I did. But even irrespective of that, when I look at the chat box, when I look at everyone worked, tirelessly, and thank you so much, everyone. And it's been a real pleasure working with all of you and learning all these new concepts. And I look forward to doing more and different topics as we go forward. All right, Professor Dhananjay, please go ahead.
Yeah, let me join Dr. Shashanka to thank you all once again. So, as you come to the conclusion of this inspiring 2-day symposium on longevity and health, I want to take a moment to reflect on the remarkable discussions that we have shared. Over the past 2 days, we have heard from pioneers in the field of medicine, nutrition, technology, and public health. We have shed lights on the innovative strategies that are shaping the future of human health and longevity, because we have experts from all over the world and from the different disciplines. The insights shared during this symposium have emphasized that extending lifespan is only meaningful when paired with a focus on improving the quality of life. We have learned about the critical roles that preventive care, healthy lifestyle, and advances in sciences and technology play, supporting longer, healthier lives. Equally important, we have been reminded that the pursuits of longevity must remain inclusive, accessible, and equitable for all. I want to express my deepest gratitude to our distinguished speakers, panelists, and moderators for their invaluable contributions. Your expertise and passions have enriched our understanding and fueled our enthusiasm for the for the important work ahead. To our sponsors and the co-organizers, thank you for your continued support in making this event a success. I must thank to Symposium Secretariat, because these are the people who work hard, and I must thank these people. That is Raghunath, Mr. Deepak, Dr. Divyalakshmi, Numer, and our volunteers, that is Sandeep, Raza, Venkata, Roni, Shubham, Ranjan. These are from IPS, and from Renix side, we have Dr. Vijay, Chaitra, Abhishek, Ayushi, Chaya, Uma, and Vachalakshi, who work behind the scene day and night for making this event a grand success. As we live here today, let's carry forward the knowledge, collaborations, and energy that have emerged over these 2 days. Let's continue the conversations, push the boundaries of innovations, and work together towards a future where longer, healthier lives are within reach for all. Thank you all once again for your participations, and I wish you good health and you continue your journey in this vital field. Together, we can truly make longevity not just a possibility, but a reality for generations to come. So thank you once again for your participations and commitment to work on this most important topic on longevity and health. We look forward to see you once again in most likely in person. So that dates and times will be shared soon. So now I'll request Divya Lakshmi to give a formal vote of thanks. Dr. Divya, over to you.
Yeah, sure, sir. So I'm Dr. Divya Lakshmi from Renix Life Sciences, and I'm here to deliver the vote of thanks. So, dear esteemed guests and fellow participants, as we draw to this enlightening symposium to a close, on behalf of the organizers, it's my privilege to express my heartfelt gratitude to one and all here who has made this event a resounding success. And first and foremost, I would like to extend my deepest appreciation and thankfulness to our guest speakers, plenary speakers, technical speakers, which include both the faculty and students from various organizations across the globe, as well as the various chairpersons. Your insights and expertise have not only enriched our understanding, but it has also inspired us to think critically about the various topics which were discussed in the last 2 days. The next, I would like to thank the sponsors for their generous support. The contributions of them have made it possible for us to bring together such a diverse group of participants with various minds and ideas. A special thanks to our organizers. I would like to mention thanks to Dr. Shashank and Professor Dhananjay, whose leadership with constant guidance led to the success of this symposium, as well as the volunteers' hard work and dedication across both teams of IIPS and Renix Life Sciences, who worked behind the scenes, ensured everything to run smoothly. And I truly appreciate their commitment and attention to detail as well. Finally, I would like to thank each and every one of the participants here and their engagement and enthusiasm, which was truly meaningful to make this gathering a success. We hope to leave with the new knowledge, connections, as well as inspirations. As we move forward, let us carry all the insights we have gained for the past 2 days into our respective fields and also continue these important conversations that have begun here. Thank you all once again.
Yeah, thank you, Divya. So there are certain announcements. I'll now request Raghunath to just make those announcements.
Yeah. Thank you everyone for joining us for the last 2 days. So we have 2-3 announcements to make before we close the session. So first thing is that we have Best Paper Presenter Award for every sessions, and the winners will be announced on our website, LongevityAsia.org, within next 2 to 3 days. The winners will be communicated through emails and WhatsApp. And also for all the participants who have participated in these 2 days in any of the sessions, we will provide certificate to them, and the certificates will be sent through emails. And next announcement is that during the registration also, we got so many queries regarding the publications. So we are planning to publish the papers in edited volumes, most likely with Springer. So interested participants can submit their final paper to us through email in 15 days. And lastly, this is the beginning, and we plan to conduct our next symposium in offline mode. Dates and venues will publish in our website soon. So thank you everyone for joining us.
Yeah, thank you, Raghunath. So finally, we are concluding our sessions. So thank you so much once again, and we'll meet you soon. So as Raghunath said that we'll meet in person very soon, and the dates and the venue will be communicated soon. So we look forward to see you again. Thank you so much. Bye-bye.
Have a good evening, guys. Thank you so much.
Shashank sir, anything?
I think we covered everything. I think we are going to
just mute. You have muted. Unmute them.
Okay, can you guys hear me?
Yeah.
Okay. I think we covered everything, and thank you for everyone. And as Raghunath mentioned, in the next 1 week, in our next few days, early next week, we will be announcing Dr. Harsh Chaturvedi Memorial Awards, and we will be announcing very soon. We will be announcing our next activities as well. Please stay tuned and let us keep in touch, and looking forward to more collaborations. And thank you all. Have a good evening.
Yeah. Thank you. Chalo, bye bye. Take care.
Bye.
Bye.